with me, I have Dr. Viraj Shingade, who is the Secretary of the Pediatric Orthopaedic Society of India. I must thank Dr. Sandeep Hemmadi, Dr. Clare Carpenter, and Dr. Claudia Maizen for joining us and agreeing to conduct this 2.5 hour long introduction to the graph method for hip screening in babies to detect DDH. As you know, we have laid down the Indian guidelines as to how to screen babies, but we have a lack of expertise as to ultrasound techniques to screen these babies. So, with a view to start initiating more and more young pedipods as well as radiologists to learn about this method and make it foolproof so that we can implement this graph method for screening ultrasound for screening baby hips in the future. With that aim, we are doing today's webinar. We are going to follow it up sooner in August with a hands-on course for about 40-45 people on phantoms using the graph method, using the um, cradle and the machines so that you get more practical orientation as to how to screen babies. So with that brief introduction, let me invite Dr. Sandeep Hemmadi to make his introductory comments, and then we can kick off the course.
Okay, thank you, Sandeep, for organizing this teaching session. I think this is a good opportunity for us to introduce the graph method of screening for baby hips. As you said, you've written your consensus paper for screening hips in India, and like in the rest of the world, the incidence of DDH in India is still expected to be 1 to 2 per thousand. So it will be a fairly large number, and pediatric orthopedic surgeons in India still have lots of open reductions that they do in their practice. And if we are successful in introducing and screening these babies, hopefully we can avoid these major interventions, try and diagnose them early in the first 6 weeks of life, and then treat them with relatively simple methods to get good outcomes. I think countries like Austria, parts of Germany, Switzerland, and even Mongolia, where a universal screening program has been introduced, there has been dramatic improvement in the outcomes for DDH. So that's all I'll say to get started. And hopefully this introduction will spark enough interest to want to learn how to use this, what is a simple and reproducible method to diagnose DDH early in life. Thanks.
So, Veera, just a few words before you introduce and welcome Claire to start the first talk. Viraj?
I think he can't hear you.
Viraj, can you
he's
hear
on
me?
mute.
All right.
Yeah, we can hear you, but I think there is some problem with the Sandeep's Sandeep Hemmadi's network is not very clear. So meanwhile, his voice is not.
No, I think
not
Sandeep Hemmadi that's fine. No, okay, that's fine. Okay, so let's start the course for today, and let me invite Dr. Clare Carpenter from Cardiff to start with the first talk of the evening, which is going to be basically the anatomy of the baby hip and the sonographic rather anatomy, and then we'll take it from there. Over to you, Claire.
Thank you very much. So, yes, I'll just share my talk. Can you see that before I start?
Yes, perfect.
Okay, great. So my name's Claire Carpenter. I'm a pediatric orthopedic consultant in Cardiff. I work alongside Sandeep, and I've been teaching alongside Claudia, teaching hip ultrasound probably for the last 10 to 12 years now. And it has not only impacted our clinical practice by early intervention and early screening, but it also has taught us from the basis to understand what is the spectrum of hip dysplasia and developmental dysplasia of the hip. And what underpins that is a sound knowledge of anatomy, as I'm sure you're all aware of at least being inside a hip. So I know this will be second nature to you. But what may not be is then translating your knowledge of anatomy into your knowledge of what you see within the ultrasound. So apologies if this is repetition for some, but it's always good to go back and review the basics. So we know in gross anatomy that the immature and developing femoral head needs to be in a concentrically placed acetabulum, and the location of the femoral head inside the acetabulum is absolutely crucial for normal development. And again, when we go back to anatomy, just to be clear that we all use the same terms, we talk in ultrasound anatomy with regards to the femoral head being centered within the acetabulum. There are a number of intra-articular structures that are visible within the ultrasound, and that is what makes it very useful to define the immature cartilaginous neonatal hip. So things to be aware of are the femoral head. When it's removed, you can see the ligamentum teres sitting within the fovea. And both the fovea and ligamentum teres are both visible within the neonatal hip ultrasound. The ligamentum teres, as you all know, is attached to the cotyloid fossa, or the true floor of the acetabulum, which is then filled with the fibrofatty pulvinar, again, which on occasion can be seen on ultrasound. The acetabulum is covered with hyaline cartilage, and in fact, the immature roof of the hip is largely hyaline cartilage when you see it on ultrasound. And it is deepened by the circumferential fibrocartilaginous labrum, which again is essential when we talk about anatomical locations within the neonatal ultrasound. Inferiorly, you see the transverse acetabulum, and again, that can sometimes be demonstrated as an intense echo. So again, knowing the anatomy is essential to then reviewing your ultrasound. If you go to extra-articular anatomy, you have a thickened capsule, again, which has intracapsular structures which become as we know it, the stabilizing ligaments of the hip. And the largest one we see is the iliofemoral ligament. And again, in this histological sample, this cadaveric sample alongside it, you can see thickened parts of the capsule, which can then be highlighted within the ultrasound. And again, it's good to understand these anatomical structures because they can sometimes become a little bit of a distracting focus when you're looking at various aspects of the ultrasound. And again, that is something that we can go to in detail if you attend the ultrasound course. Above the capsule, you see the stabilizing, reflected and straight head of the rectus femoris tendon. And again, that is one of the structures that we look at when determining the types of hips we see on ultrasound. So on the cadaveric slide we see here, we see the cartilaginous femoral head. Immediately above that, we have the triangular fibrocartilaginous labrum, which we will talk about later on. We then will have the capsule, we then have a gap, which we'll talk about, and then we have the thickened, reflected head of rectus femoris. And again, all these are seen within the standard plane of the ultrasound. When we look at an ultrasound, we take slices of the child's hip, which includes the femoral head and the pelvis, almost in this orientation. And again, it's it's good to remind yourself that when you're looking at the Y-shaped triradiate cartilage, you have the bony ilium above, your pubis anteriorly, and your ischium posteriorly. And again, when you are scanning through your hip, it is good to know where you are, because Claudia will explain to you the standard plane, or sorry, Sandeep will explain to you the standard plane a little bit later on. And so when we talk about ultrasound terminology, if there's any radiologists or sonographers online, I'm sure they are more adept at this than we are. But what we know is when you pass an ultrasound beam through tissue, if the tissue has a high fluid content, a high water content, then those ultrasound beams will pass fairly easily through tissue. If the tissue has very low water content, such as in the cortex of bone, those ultrasound that ultrasound beam is reflected back in the form of an echo that is picked up by the machine, and then it generates an image, as we have here on the right-hand side, of a standard image of the neonatal hip. So bone will be quite intense and bright echoes, beyond which the beam cannot pass. So then you have an acoustic, or what we call a sound shadow, which will appear quite intensely dark or black on the ultrasound image. Collagen and fibrocartilage, again, it's tightly packed fibrous tissue. There's not much water content. And so again, they appear to have really good echoes, and so they will appear bright. Fatty and fibrous tissue, again, that are not so loosely packed, they have increased water content, have weaker echoes. The echoes are probably of intermediate density, as we see between the black of behind the intense cortex of bone. Hyaline cartilage has no echoes because, again, it has quite a big fluid content, so the ultrasound beam can pass straight through it. The other thing we talk about, and again, Sandeep is going to cover this a little bit later on, is we talk in ultrasound terminology. So as well as we talk about echoes and sound shadows, we also talk about the location of the hip. And again, this is something that you might not be used to, but we talk about centering of the femoral head, and whether that femoral head is centered within the acetabulum or whether it is decentered, i.e. it is not centered within the acetabulum. And again, Sandeep will kind of embellish that a little bit further on. And of course, we all know this is why ultrasound comes to the fore with regards to the identification and quantification of the neonatal hip, is because the majority of the proximal femur and the developing acetabulum within the neonate is largely cartilaginous. And as you can see here, in a very young specimen of a hip, that the femoral head, the longitudinal growth plate on the neck, and the trochanteric area are all contiguous. So the proximal femur is all in continuity at this stage. And as the baby's hip develops, if it is in the correct position, with the correct forces being applied to it, that is when you see the normal maturation happen and the normal ossification. And as you can see here, the cartilaginous proximal femur gains the secondary ossific nucleus first within the femoral head. That then expands. The neck also then expands to obliterate the neck, the cartilaginous neck, and soon it will join with the trochanteric center. Again, that happens depending on male or female, and you all know that that matures then between the ages of 14 to 16. Again, understanding the maturation of the acetabulum is also important. And the acetabulum, again, is largely cartilaginous to allow for growth in width and depth of that acetabulum as the child's hip increases in size. And so we're all au fait with the growth plates around the proximal femur, but you also have to be aware of the growth plate and the ossifying front that is related to the acetabulum. And this is really important because not only can we get disruption to the growth plate of the proximal femur, but you can also get disruption to this acetabular growth plate, which is what we see when you have some residual dysplasia later on. So again, knowing the anatomy is highly important, and again, respecting the anatomy and the cellular microstructure is really important to prevent any long-term consequences of your treatments, which we'll talk about later. So again, what you can see is then if we are all in the standard plane, and we'll talk about how to get that, but you can see that the anatomy in a cadaveric model and the anatomy on a standard plane ultrasound can be compared quite accurately. So you can make quite educated conclusions about the spectrum of abnormality within the hip. So graph and teaching graph hip ultrasound is very didactic. We make sure that we adhere to all the checklists so that we get reproducible ultrasounds each time. Because unless you get a reproducible ultrasound, how do you make any judgments on what your treatment is doing and how that hip is improving or not with your treatment modality? And so our first checklist is our anatomical checklist. And if you look at this cadaveric section here again, what Graf has looked at and researched the whole of his career is how to get these anatomical structures in view and then how to get the standard plane. And so what he describes is the chondro-osseous border is the first part of the checklist. Then he goes to femoral head, which is number 2. He talks about the synovial fold, which is the reflection as the capsule comes down into your piriformis fossa. The capsule then comes out and it goes over the femoral head to insert onto the perichondrium of your pelvis. The labrum, number 5, which is your triangular fibrocartilaginous structure, as we have said, which envelops in a horseshoe structure around your acetabulum, your hyaline cartilage roof, and then your bony acetabular roof. And again, histologically, this also mirrors what we see in gross anatomy. So we'll just go through that. So again, if we go through the sonographic anatomy as compared to the histological anatomy, I'll just see actually if I can get up a mouse. Okay, can you see that mouse there, Sandeep? Okay, let's see.
We can see that.
You can see the mouse.
Yeah.
Okay.
Yes, we can. Yeah.
Okay, so the anatomical checklist. So we go through the chondro-osseous border, which is this intense white echo, because this is your developing and ossifying diametaphysis of the femoral shaft. You then come to your femoral head, and you come all the way around your femoral head to this white intense echo, which is your synovial fold. So whereabouts your capsule will start, it will come over your femoral head, and we carry on following the capsule up as it inserts onto the pelvis. But before we get to that, we have this white intense echo, which is the labrum, and that is labeled number 5 on the corresponding histological image. You then have your hyaline cartilage roof, which is black, as we said earlier, because of the fluid within it. And then we go to our bony roof of the acetabulum. So again, if we come over to the histological slide, we have our chondro-osseous border, we have our femoral head, we have our synovial fold, we have our capsule. This is quite an elongated labrum, but again, we talk about we look at the center of the labrum, we come across our hyaline cartilage roof, and then this is our bony roof. Again, to take these all individually, because the checklist is really important that we get this right. If you get your first checklist wrong, then it makes subsequent errors in your identification and your subsequent diagnosis thereafter. So again, we've got our chondro-osseous border. Then we come on to our femoral head. But of course, our femoral head is not perfectly round. It's almost like, for want of a description, as we come from Wales, it is like a rugby ball shaped or ovoid in structure. So again, when other types of ultrasound classification look at the percentage cover of the femoral head, if you take an ultrasound that is out of plane, your femoral head coverage is going to be inaccurate. So we don't tend to use femoral head coverage because of the fact the femoral head is not perfectly round. Within the femoral head, you see white flecks. Those white flecks are the immature sinusoids, or the blood lakes within the hyaline cartilage of the femoral head. And as we know, as the femoral head matures and you get a primary ossific nucleus form, the more mature vascular supply starts to form. So those little white things are good, normal, healthy blood supply to the immature femoral head. And again, sometimes you see a little black line right on the femoral head. It almost comes round. This is not fluid, okay? This is just an echo-free ring that we see just on the femoral head, and you can just about see it there. And again, these are all the peculiarities of when you're getting used to looking at ultrasound. Of course, we are reliant in ultrasound for there actually not being an ossific nucleus there. And as you all know, in developmental dysplasia of the hip, unless that femoral head is centered with the normal forces going across it, the ossific nucleus may not well be formed. And it's pretty much delayed in cases of DDH. We know that the ossific nucleus starts to be visible about 2 months earlier on the ultrasound because of the coalescence of those cellular structures within that femoral head. So we do see it a little bit earlier. And again, the ossific nucleus is not round, and very often it is not centrally placed, which again is why early X-ray is not useful or as useful at looking at determining hip dysplasia and the grades of it. Sometimes you can only see half of the ossific nucleus, and it looks like a moon on ultrasound because, of course, the ultrasound beam behind it is largely you get an acoustic shadow, so it stops the beam, letting us see what is behind the ossific nucleus. So again, when you have a big ossific nucleus, such as in a larger baby, ultrasound becomes less useful. Again, we cannot measure the size of it, and as I said, it sometimes will block our view. So we can't use the ossific nucleus. So the next thing we look at is our synovial fold, which we have said it's number 3 on this histological specimen. And again, from that comes the capsule. The labrum becomes extremely important and central to not just seeing that we're in the standard plane, but also for measurement. And again, this is the labrum. And there are a number of definitions for where the labrum is. It is lateral, so it's further lateral. And remember, the baby is sitting on its side. So the lateral is, as you're looking at it, to the left-hand side. It's lateral, and it sits below the hypoechoic cartilaginous roof. It is always in contact with the femoral head. There's what we call a perichondrial gap, which again can be explained further within the course. And again, it sits below the capsule, where the capsule starts to deviate from the femoral head. And that becomes relevant when you're looking at decentered or dislocated hips, because these labra can be distorted and out of where their normal position. The hyaline cartilage roof is black, as we see here. And the hyaline cartilage roof, as we said, has no echoes, and the fibrocartilaginous labrum is highly echoic. Finally, we come on to our bony roof, which is black. And once we've gone through our anatomical checklist, we're on to defining where the kind of edge or the bony rim of our acetabulum is. And we know it is on a curve. And when you have a kind of a sinusoidal or S-shaped curve, there is always what we call a turning point, where the concavity meets the convexity. And sometimes there is a black or acoustic shadow at this point, which makes it easier for us to determine where the turning point, and in some translation, it's where we think the bony rim is. And again, depending on what you've read, will depend on how this translates into English. And again, this is something we talk about in the course. And finally, you have your completed checklist. Your chondroosseous border, your femoral head, your synovial fold, your joint capsule, labrum, hyaline cartilage roof, bony roof, and then you define your turning point, which is your concavity to convexity. And if you have to get this right, because we all know in papers when we look at scans that again diagnostic errors, 50% of them will result in this list not being correctly identified. Thank you.
Thank you, Claire. That was lovely. Can you just unshare your screen for a moment?
Yeah.
Yeah, thanks. So, Bhushan or Ashish, are there any questions that you might want to ask Claire at this point? Some clarification that we need. So I think, yeah, please go ahead.
Excellent talk. So just one question I always been, what is the sort of learning curve, or, what do you suggest? Is there a way one can learn? Because someone who is completely naive to ultrasound has never done it. How much time does it take?
That is a really good question, because the ideal is you learn as a team and as a group. And so as peds orthopedic surgeons now in the UK, we don't ultrasound. Our sonographers will ultrasound, because their attention to detail and their ability to maintain the standards are much better, because we are always distracted by our other knowledge and our want to intervene and treat. So it's always better if you do this with somebody else who just ultrasounds, right? And so that you can maintain the focus and the attention to detail. And the way we did this in our own hospital was we, as a team, would meet we would review the ultrasounds together. We would discuss ambiguities or questions that arose, because there is a learning curve. And so now, as part of our ongoing kind of quality standard, every year we meet, we go through difficult scans. Our team, everyone who ultrasounds, has to then look at 10 scans every year. They go through the checklisting process, they measure, and they come up with the typing, which we will talk about. So again, it's a constant validation of your standards and your process. So we're still maintaining and learning, because as with all things we do in pediatric orthopedics, there is always something out there, the 1 in 1,000, or that will catch you out. But again, what this screening process does, it allows the standardization for you then to go back and unpick how to understand where things might have been missed or gone wrong. So again, for our sonographers, they had to do 50 scans that were mentored by their senior sonographer before they were allowed to scan on their own. So again, what I would say is, for anyone who's starting to learn, and I would suggest, as an orthopedic fraternity within India, you set up mentorship for people who are experienced in scanning. And I would probably say, for even the experienced scanners, sometimes they say they run into problems. So it's good to speak with other people about their opinions or what you feel. So don't be frightened or scared, or even if it goes wrong, right? This is about doing the best that you can with the best process you possibly can. And can honestly, ultrasound and early diagnosis is without doubt now the gold standard.
So,
thanks. Sorry,
Viraj, any question there? Bhushan?
That's absolutely fine. Yeah. Just please go ahead.
So just one from my side, Claire.
Sure.
At what age do you think that the first scan should be done for the baby?
So I think, so again, in the UK, there is a diversity of opinion. So if you have a hip that is unstable clinically, okay, and you picked it up at birth, so in Wales, they would get a scan at 2 weeks. So baby would go home, they'd come back at 2 weeks. We'd allow the neonatal instability period to try and settle. We'd get a scan at 2 weeks for a clinically unstable hip. For hips then that are clinically stable, but we know they have risk factors for hip dysplasia, they come at 6 weeks. Because we don't see any point, if it's clinically unstable, to wait till 6 weeks.
Yes. Okay. All right. I think we'll come to the other questions later. Let's move on. Sandeep, I think next talk is by you on standard plane.
Okay. Thanks. I'm going to try and share my screen, and if you just give me some feedback to let me know if it is on, then that'll be great. Give me 2 minutes. Are you seeing my screen?
Yes.
Is it in slideshow now?
Yes, we can see Sandeep.
Not yet. Yeah, now full screen. Okay. Yeah. Go ahead.
Okay, fine. So I'm going to check if the slide moves forward. Yes, it is. Okay, fine. So Claire, thank you for the talk. I can't emphasize more that getting the anatomy right, the ultrasound anatomy, is probably the single most important thing to learning this method. So we'll continue that. So I think the key things that even some orthopedic surgeons will learn from this ultrasound anatomy is that the femoral head is not round. Okay, the femoral head is more oval in shape. In a neonate, it's not round. We know that the ossific nucleus is not in the center of this femoral head which is not round. And thirdly, we know that the acetabulum is not symmetrically deep. Now, these three things in the anatomy make it difficult for us to decide when you get an ultrasound scan. The ultrasound scan is like a tomogram. It's like a single cut through the acetabulum. How do I decide where to take this cut? Because once we define that, we need to define that. Otherwise, because the hip is not symmetrically deep, if you take a cut in the anterior section, you will measure a shallower acetabulum. If you take a cut in the posterior section, you will measure a deeper acetabulum, and we'll have no consistency and reproducibility. That is the crux of the graph method, that it defines a standard plane so that your pictures done today versus tomorrow, or the same picture done in your city versus another city can be reproducible, okay? So we're all used to measuring the acetabular index. And on a plain film, when you have both the hips visible or both triradiate cartilage visible, we use our horizontal line as our standard. And then we use the, if you can see my mouse on the screen, use the line from the triradiate cartilage to the edge of the acetabulum to measure the acetabular index. Now, when you're doing ultrasound and your ultrasound beam is coming from the left side of the screen here, you're only going to see one hip. So that sets a problem. You can't draw your horizontal line because you haven't got the other reference point. So the next best thing you could do is use this vertical line here. And therefore, if you think of what we measure as the alpha angle on ultrasound, is 90 degrees minus this acetabular index. And we use this vertical line as our reference point. So that's our vertical line. And that's our reference point for measuring the alpha angle. And this is effectively what you measure when you do the ultrasound in a standard plane. So just to give you an orientation, it's not very different from what you do on plain films. It's just that you haven't got the other hip visible in the ultrasound. So you use a reference point, which is 90 degrees to your horizontal line. And that then becomes the alpha angle there. Okay, so to make it reproducible, we have to get our scan through the center of this acetabulum. Now, the center of the acetabulum we know is where, if you saw the anatomical picture, where the Y-shaped triradiate cartilage is visible, this is the lowermost point of the ileum, and we are going to use that as one point in that standard plane. Now, for a plane, you need to have 3 points in 3 dimensions. So we'll start with this one. So we must see this lower limb in our scan, and that becomes our first point. Now, even if you go through this center point, if you see these lines I've drawn here, 1, 2, and 3, 1 would be what we would call an anterior cut. That would be shallow. 2 would be what we would call the standard cut, which was this measurement we want to make. But if you go to posterior, then you'll get a deep cut, okay? So you want this ileum in this middle section of the acetabulum. The ileum is at its straightest. So if we get the cut through the center of the acetabulum, but also through the straight part of the ileum, you will get this vertical standard straight vertical ileum. Okay, so that gives us our 2 points. And that's the lower limb. That's the lowermost point of the ileum, which you're seeing in the picture here. Now, if the acetabulum was a perfect hemisphere, it's not, but if it was, then life would be easy, because whether you cut it there or you cut it here, you would still get the same depth or the same hemisphere. But that's not the case in the human acetabulum, and therefore we have to make more efforts to standardize the plane. So here is the left hip, and we're looking at it end on. I've just marked the anterior, posterior, superior, and inferior there just to orient you. And you can see, and anyone who's looked inside a hip while doing a hip replacement will know that the posterior wall is always deeper, the anterior wall is always less developed or shallower. And there's a reason for it. During evolution, when we were walking around on our forelimbs, the part of the acetabulum that took all our body weight was up here where you see my mouse. But as we then went on to 2 feet or using just 2 limbs, your pelvis has rotated, and then you've got upright. So the deepest part, which was originally at 12 o'clock, is now moved into the posterior part. And therefore, evolution has given us a posterior wall which is deeper and anterior wall, which is shallower. And therefore, we've decided to use the middle point here to get a good balance of what we are going to measure as the standard plane. So the first point in our standard plane is this center of the lowermost point of the ilium, or where the triradiate cartilage, the bony bit, ends. On the ultrasound, you can see it here, and in our bony specimen, it's in the center there. If we cut along line 1, this is called the anterior plane, and you can see that the shadow of the ilium is going or pointing towards the ultrasound beam, where the ultrasound beam comes from. This is the skin. Then you have subcutaneous fat and intermuscular septums, muscle, and then the ilium. This is not the plane that we want, because remember, in all next 3 pictures, it's the same hip, the same acetabulum. You can see how in an anterior cut, the acetabulum looks quite shallow here. Now I'll show you, if I use in the same hip and I cut a posterior plane, that means from, say, 1 o'clock to 7 o'clock, the same hip looks a lot deeper, but the ilium goes away from where the ultrasound beam is coming. What you ideally want is this picture, where your beam is perfectly going through the center and also along the ilium, and then that gives you a straight ilium, and this is the true reflection of the depth of the acetabulum. And then you'll see the femoral head looks slightly oval. So here I've put all 3 pictures for you to see. Even when you go to, first you have to go through the center of the acetabulum. So you must see this bright spot at the lower limb, or the lowest point of the ilium. And even after you get this bright spot, you need the ilium to be vertical. But again, you must first get this bright spot visible in your picture and then correct the plane, rather than try to get a straight plane and compromise on this bright spot, because that is the single most important point. You first get that, then you adjust your probe to make your ilium vertical. The labrum is the 3rd point in this standard plane. And though in the tomogram, the labrum appears as a little triangle, that's because it's a tomogram of this structure. And the labrum, you can see, it starts from about 7 o'clock. It goes all the way around to 5 o'clock. And inferiorly, this connection is maintained by the transverse acetabular ligament. Now, when anyone who's used an ultrasound probe, you know that you get a good image only when your ultrasound beam is perfectly tangential to the structure that you're seeing. So the labrum must be visible. And for the labrum to be visible, the probe has to be tangential to the labrum. So when you get all 3 points, you see the lower limb here, an ilium which is vertical. So the lower limb must be a nice bright spot. The ilium must be vertical, and the labrum must be visible. When all 3 are present, we say that we are in the standard plane. Now, probably a better technical term rather than standard plane would say a standard sector, because a couple of millimeters either side of this plane, you will still get all 3 of these images visible. So that's the labrum there. That's the labrum there, which you saw in anatomy. And so on the line drawing, my labrum is here. In the and histology specimen, it's this little triangle here, and on the ultrasound, it's this bright spot there. So why do we need this standard plane? Because we need reproducibility. As I explained just as I started the talk, that our femoral head is not round. Our acetabulum is not equally deep. So unless we define which part of the acetabulum you're going to get your ultrasound tomogram, for want of a better word, if you don't define that clearly, in the same baby on the same day, if you make your images slightly anterior or slightly posterior, you will get different measurements, and then your system will not be reproducible. So we need to define the standard plane to have a reproducible system. And to define any plane in geometry, you need 3 points, and therefore we have the 3 points that make up our standard plane. They are the bright spot of the lower limb, a vertical ilium, and a visible labrum. So this combination is called checklist 2. So Clare taught us checklist 1, which was to make sure that we had all the anatomical structures visible. Once they are visible, in checklist 2, you have to check that the lower limb is bright and visible, the ilium is straight, and the labrum is visible. I'm just going to cover one other thing there. So we'll come to this exception in a minute. So Claire talked about the terms decentered. Now, in clinical practice, we talk about a hip being located or dislocated, but we also use a term called the hip is subluxed. Now, in ultrasound, there is no equivalent of sublux. It's meant to be black and white. You're either centered or you're decentered, and you define very well these two terms. And then when you teach you practically on a course, I'll try and explain to you exactly when you say a hip is centered and at what point a hip is decentered. Now, in this image here on the left, this is a centered hip. And if I had to very simply explain it to you, I'd say when the labrum is below the turning point. So the turning point is where the concavity becomes the convexity. And on a training course, we'll spend lots of images to teach you to pick out where is the point where the concavity becomes convexity. That in this picture, this where my arrow is the turning point, and this is the center of the labrum. If the labrum is below my turning point, I have a centered hip. I'm going to try and move away and see if you can see my arm, okay? So if you think of a little helium-filled balloon under my arm, at the two extreme, everyone agrees, that whether a hip is centered or not. So if I put my hand here, let's say my axilla is the turning point, and my hand here is my labrum. If I put my hand across like this, everyone would agree this balloon is contained under my arm or is a centered hip. If I put my hand here, then the balloon with helium is going to rise up or go up this way, and it will dislocate. So at this extreme, it's easy to decide that's a dislocated hip or a decentered hip or a balloon which is not being contained. And at this end, it's easy. But when I'm somewhere here, that's when you need a system to tell you when a hip is centered and decentered. And that's why the measurements and the other parts of this system help you to consistently make the right diagnosis. Now, with just eyeballing, you can see that this femoral head is well under the acetabulum. The turning point is here, labrum is below. This is a centered hip. By eyeballing, you can see that almost 90% of this head is no longer under the ilium here, and the labrum is quite high. It's well above the turning point. Therefore, this is a decentered hip. One comment I'm going to make is, in the entire graph method, in the teaching, in the books, on the course, and in the manuals, we are always talking about a hip, an ultrasound image, which looks like a right hip AP. Okay, there are some ultrasound machines where the ilium can be turned 90 degrees, but if you're reading the book, everything will only make sense if you talk about a right hip AP image, because you're talking about the labrum being above or below or something being medial or lateral. If you change the orientation of the image, it really can confuse people when they're first starting on the system. So just remember, for all our training purposes, we are always using a right hip AP image. And then I was going to mention that exception. There is an exception to checklist 2, as in you can use an image which doesn't satisfy checklist 2 if it is clearly obvious that the hip is decentered. Because in a decentered hip, you will not be able to get the femoral head and all the structures in the acetabulum in one standard plane, because the hip is now outside the standard plane. Okay, that's all I was going to talk about the standard plane. I will stop sharing, Sandeep, and I'm happy to take any questions that my people might have.
That was nice, Sandeep. So a question here that I wanted you to zoom out a little bit for most of us who haven't seen or learned from graph. When you say tilting errors, or when you don't see the standard plane, do you have an image or a picture showing actually the hand of the person doing the ultrasound with the machine to just demonstrate what you showed on a sonogram? Because
yes,
that will give.
I can do that for you. There is a
or you can show with your hand, because basically what people are seeing as an image, they might not be able to correlate to what you mean by the transducer not being perpendicular.
Okay. If you give me 2 minutes, I'll share a different picture. I have a whole talk on tilting, and I'll show you the method in that in 2 minutes. Okay. So if someone wants to just
I'll ask you another question.
I'll find the thing in a minute.
So maybe Claire or Ashok or even Claudia can answer. Is there a chance that since we are looking at static films and we have such a nice German standardized checklist, can AI do this for us? Why do we need to break our brain over it?
Shall I start?
Sure.
Yes, of course AI can do it, as is AI going to do a lot of things within our profession. However, you have to understand the principles by which AI is underpinned. AI only is doing what some human has inputted into the system. And as orthopedic practitioners and clinicians who are responsible for our babies and patients, you have to have a basic understanding, because at some point something will go wrong, or the AI will meet the end of what they can do for now, right?
Yes.
And so AI is very good at doing things that in quick, efficient time that has been taught. And yes, it can help you to get to the typing, to agree whether you're in the standard plane, and you should allow that. But you should understand the origins of why the computer was taught that way. And so and again, we're all going to come into the AI generation and revolution, but you still cannot skip understanding the basic principles. And this is what is so kind of enlightening about the graph method for me. I still consider myself a fairly junior orthopedic consultant, even though I'm probably not that junior anymore. But sometimes when we were taught hip dysplasia, you're very much taught the surgical options or the treatment for it without taking the time to then go back and really understand the underpinning principles of the pathology. And now with ultrasound, to really quantify and qualify that pathology really well. And again, this is the start of then what goes on to develop the treatment regimens, etc. Because we're all fairly didactic in our approach to treatment, when actually if we understand, the treatment actually becomes very much more bespoke to that child and to that underlying hip pathology.
Yeah.
If I just a quick one now to AI. I think AI has definitely the potential to take over on that end. But you need to understand the differences between a proper standardized picture to understand what AI model is actually giving you. So you have to understand what pictures is this AI model based on? And we know there are AI models out there that are sort of claiming to do the graph, sort of trained on the graph method, but they don't even recognize the chondroosteus border, okay? So we have to be very careful what AI model we are using.
Okay.
And
Okay.
So
Back
Sandeep,
to Sandeep.
I've got something to share, so I'll show you what I meant by what you mentioned in terms of standard plane and tilting. Okay,
Yes.
so let me know if you see my screen now. Are you seeing it?
Yes. Yes.
Okay, give me
I think
one
that
moment.
will clarify things.
Yeah, okay, I'll explain it. Okay, so if you're seeing a slideshow now, is that right? You can see it? Okay, so this picture, so I'm showing you here, if your probe is in that position that you're seeing in the picture there, where your beam is coming from anterior to posterior, you inadvertently will get an anterior posterior tilt. If your probe goes in this direction, you'll get a posterior anterior tilt. If your probe were to tilt there because you have a prominent trochanter, you'll get a craniocaudal tilt. I don't want to confuse people with all these tilts, but I will explain these in detail when you're teaching on a basic course. But in terms of what tilts are, these are the 4 tilts. And to avoid these 4 tilts, we now tend to use we recommend using this cradle with a probe guide, so that the probe cannot now tilt anterior posterior, craniocaudal, or caudocranial. I just want to make one point here that you have to place the baby in a lateral position in the cradle. The probe guide and cradle are not 100% foolproof. You still have to look with your eyes and make sure the baby is in the right position. And finally, all hip ultrasounds are done by a linear transducer. If you use a sector scanner, you will automatically introduce tilting errors right from the start. So that's not recommended. So anyone doing hip ultrasound, to get reproducible and use the graph method, you have to use a linear transducer and not a sector scanner. Okay, I'll stop sharing, Sandeep, unless there's anything else you want me to
wonderful.
show.
I think that made it very clear for all those who are signing into this course, this webinar. It's how you do the scan. If you don't hold the baby dead lateral and your probe is either too anterior or too posterior, you will not get a standard plane. And that standard plane is then not usable. If you feed that to the AI, it's going to make a mistake.
Yes,
but maybe AI can sort out saying that these are usable films and these are non-usable films before we proceed. So Ashok, if you are listening, you have to develop a model for that. Right. So let's move on to Claudia, who's going to talk to us about the types of graph types and the measurements a little more mathematically. Thank you.
Thank you very much. Can you see my screen?
Yes, thanks.
Brilliant.
Yes.
Fantastic. So I'm going to talk about the graph hip types. So there's usually 2 talks. So I'm going to try and shorten it down to 1 talk. As Sandeep already said, in the course, this is covered in more detail, of course. So just make sure I can get the next one. So the pictures, like in the other talks, are mainly from Professor Graf and from Stolz, Albert. So just an acknowledgement here. So as Sandeep said, for our sort of the first step in our process is to, sorry, I don't know if you can see this as well. I'm trying to get this bar out of my picture, out of my view.
No, it's working fine. We can see.
So after our checklist 1, you've decided whether your hip is centered or decentered. This is probably the most important step before you go ahead. Again. Yeah. Okay, there we go. So with our sonographic hip types, with our description that we start off with, we can differentiate already between type 1, type 2, and type 3 and type 4. So we decided on, depending on where the labrum lies in relation to the turning point, whether a hip is centered or decentered. Type 1 hips and type 2 hips are the centered hips. The type 3 and type 4 hips are the decentered hips. So in a decentered hip, we have already heard the labrum is below the turning point. Here, just to underline that, in a type 1 or 2 hip, in a centered hip, we have the turning point, we have the labrum, and the labrum is clearly below. In a decentered hip, again, we've got the turning point, we've got the labrum identified, and the labrum is now above the hip, the turning point. So when we're describing a hip, what are we actually describing? So what we are describing is the bony roof, we describe the cartilage roof, and we describe the bony rim area. So in our picture, this is our bony roof, our cartilage roof. So as soon as we're coming to the turning point, where the bone lifts away from the femoral head, is where the cartilage roof is actually covering the femoral head. And our bony rim area, just also to reiterate, this has caused a lot of confusion in the past, where the bony rim was confused with the turning point. So that was a problem with the translation of the German turning point. This has now been changed in the new translation, in the new graph book. So we differentiate between the turning point, which is the concavity turning into the convexity as part of the description of the bony roof, and this bony rim area, which is the most lateral aspect of the acetabulum, of the bony acetabulum, is something that we use in the description. So our bony roof can have 3 qualities. It can be good, it can be adequate or deficient, and it can be poor. Our cartilage roof we describe with either covering or it is displaced. When it is displaced, we decide between whether it is displaced upwards or displaced downwards. I'll show you on pictures later. The bony rim area, so the most lateral point of the bony acetabulum, has a certain shape, which we describe either as angular or blunt. or round or flat. So all these terms are important to standardize as well. So this is part of that standardization, that if somebody describing a hip in London will describe the same thing as somebody in India or in Cardiff or elsewhere in the world. So we all talk about the same thing. And when we are using a certain term, somebody else elsewhere will know exactly what we are describing and how it is meant to look. So in our manual, in our course, we have also this sort of table, which is very useful to also print and maybe hang on the wall in your ultrasound room. Just help yourself to sort of with the description. And also it shows you very clearly that with certain terms, you automatically align in one row, essentially. You can describe a type 1 hip with a good bony roof, an angular or blunt bony rim area, and a covering cartilage roof. Whereas, for example, a type 4 hip has a poor bony roof, a flat bony rim area, and the cartilage is displaced downwards. So with these words and these terms that you've chosen, you can already make a decision which type of hip joint you're describing. So just in a bit more detail, our type 1 hip is a centered hip. So centered hip means it has to be in your standard plane. We start to describe the bony roof, which is good in a type 1 hip. The cartilage is covering the femoral head. We can see here, you see my mouse, we have the labrum here, which is the end of the cartilage or the acetabular cartilage. It is covering the femoral head. The bony rim area, so this outermost point of the bony roof, is here angular, so it has a sharp angle. And here on the side, you can see an example for a blunt bony rim area. So it's essentially just slightly blunted off, not quite angular. So this would describe a type 1 hip joint. Our type 2 hip joints, they are also centered hip joints. So also here you have the labrum below the turning point, and the cartilage is still covering the femoral head. The bony roof can now be either adequate or deficient, which depends on the age of the baby, but also on the severity of any sort of dysplasia of the bony roof. The bony rim area in this case is round, so it's not angular or blunt anymore. It's not as well defined. It is now starting to round off. So we decided the hip is centered, and we described our turning point versus our labrum. And the difference now between a centered hip, type 1 hip, and a centered hip, type 2 hip, is the essentially the not percentage, but it's sort of the amount of coverage, either provided by the bone right up to the turning point, and from the turning point, the hip is covered by the cartilage. So this relation between how much of the femoral head is covered by bone versus cartilage can give you an idea whether a hip has a good bony roof or if the bony roof is adequate. So this relation changes in the type 2 hips. So we don't have now half of it covered by bone, sort of by the bony acetabular roof versus the cartilaginous acetabular roof. This now changes this relation. We now have the hip still covered, but we have more cartilage. You can see here large cartilage versus small bony contact area with the femoral head. So the type 2 hips can further be subdivided into the type 2As, Bs, and Cs. But to subdivide these dysplastic or immature hips, you have to have measurements, and you also take age into account. So we skip that at this point, and we go on to type 3 hips, which we can also type by just description alone. So these are the hips that are now decentered or dislocated. The bony roof in type 3 hips is poor. So you have very poor coverage of the femoral head or contact of bone with the femoral head. There is some cartilage still above the femoral head, but it is displaced. So we have the labrum here as a little indicator. It is above the turning point. So it is a displaced or dislocated hip. And the cartilage is now pushed upwards. So as the hip slowly slides out of the the bony acetabulum, it takes the cartilage with it. So the cartilage is pushed up, and the perichondrium, which is the outline of this cartilage, which is anechogenic on the ultrasound, is sort of, it's going upwards, which gives you an indirect sign that there's still some cartilage above. The bony rim area here is now flat. We can see that's not blunt, that's not round. This is really flat now. Below you see a schematic picture showing that the perichondrium, which is covering the cartilage of the acetabulum, is going upwards in type 3 hips. Here a diaphanogram in comparison to an ultrasound picture. This is essentially showing the same thing in the same hip. You can see here indirectly with an aerogram, we have cartilage here still above the femoral head, but we can see that the femoral head is not displaced out of this original acetabulum, but there's still some cartilage taken up with the head, above the head. Here we can see this in the ultrasound picture. Here anechogenic, this is our cartilage, which is covered by the perichondrium. Perichondrium is still going upwards. There's still a little bit of cartilage above the femoral head. So in comparison to these type 3 hips, the type 4 hips has now further progressed in its dislocation process. So first the hip or the femoral head takes the cartilage with it and pushes it upwards. Eventually the femoral head then, if I show this here, is then pushing the cartilage downwards. Yeah, we can see here in the schematic picture again, here down here we have the original acetabulum. Remember, type 3 hips are pushing the cartilage up, and then the hip slips out of this cartilaginous cover and pushes the cartilage downwards. Yeah? So the bony roof in type 4 hips is again poor. There's not much contact of bony roof with the femoral head anymore. The cartilage is now pushed downwards as the femoral head has continued to move upwards. Sorry, going backwards. And the perichondrium, which is again covering the cartilage, is now either horizontal or even dipping down in comparison to the tip of the femoral head. Bony rim area clearly flat again in this picture in the type 4 hips, the same way as in the type 3 hips. So maybe important to mention here. So I was still taught when I started my orthopedic training 25 odd years ago, during an open reduction, that what you can see is the inverted labrum, which is sort of preventing that femoral head to reduce into the acetabulum. And I was still taught to remove it or to incise it to make sort of the acetabulum bigger for the femoral head to sit in. So what you're actually excising, or what we have incised, was the growth plate of the acetabulum. So this down here is not the labrum. It is still above here at the end of our cartilaginous roof. And what we have down here, preventing the femoral head from reduction, is actually part of our cartilaginous roof. So in decentered hip, to summarize, the perichondrium is key. If the perichondrium is going upwards, it's a type 3 hip. If the perichondrium is going downwards in a decentered hip, this is a type 4 hip. Here again, in comparison, we have a hip that is decentered. Our labrum is above the turning point. The cartilage is still above the femoral head, and the perichondrium is going upwards. In comparison, the picture of a type 4 hip, we again have the labrum above the turning point, so it is a decentered hip. The cartilage is now below the top of the femoral head, and the perichondrium is more parallel or dipping downwards. This is a type 4 hip joint. So to summarize the description, with description alone, we can decide whether a hip is centered or decentered. For the centered hips, we can say it's a type 1 or more likely a type 2, but we cannot subdivide the type 2 hips. And we can decide in a decentered hip whether the hip is a type 3 or type 4 hip joint. So to subdivide the type 2 hips, so the dysplastic area, which is in other classifications a gray area, and user dependent, whether it is pathological or not pathological, we can here in the graph method clearly use age as well as measurement to subdivide those dysplastic but centered or stable hips further. Important to say again is you cannot measure a hip that is not in the standard plane. So if a femoral head is dislocated, by definition, it has moved out of the center of the acetabulum. So it's not in a standard plane anymore, and therefore those decentered hips should not or must not be measured. You're measuring the wrong part of the acetabulum if you do. And as Sandeep has explained, the hip is usually dislocating posteriorly, where you have a better coverage or a deeper acetabulum. So you might overlook, if you just concentrate on measurements, that a hip might be dislocated. So it is important to follow the steps, and the measurement is the last of those steps. So you go through your checklist 1, you decide if a hip is decentered or centered. If it is a centered hip, you use the usability check. And if that is all fulfilled, then you're allowed to measure this hip and make a subclassification. So type 3s and 4s should not be measured, with a very, very rare scenario where a type 3 hip is about to dislocate, but just about still in the standard plane. So how do we measure? We have 3 lines that we draw. We have a baseline, which comes from the attachment of the proximal perichondrium on the ilium. So we identify this point, which is also called Z point, and then we pivot this line until we touch bone. So to demonstrate that, that's our Z point. We have the proximal perichondrium attaching to the ilium, and then we have a line that we just draw tangential to the bony roof. After we've drawn our baseline, we draw a bony roof line. So this is now a line that is tangential to the bony roof. So you essentially imagine you're using a ruler, as it was done in the past on printed out ultrasound pictures, and you now bring this ruler closer and closer and closer to the bony roof until it touches the bony roof on both ends. The ends are the lower limb, and then depending on the shape of the bony roof, and you come closer to it until you touch the bone. You don't cut through bony roof. You don't go into the echo of the bone. And the important here again, the turning point is not relevant to draw the bony roof line. So the bony roof line does not go through the turning point. It just touches bone. So again, to demonstrate that on an ultrasound picture, we have identified our lower limb, which is the brightest echo as we are performing our ultrasound. And from this point, we want to touch bone. And you can see here quite clearly, our turning point would be here. If we would draw this line through the turning point, we would cut part of that bony acetabulum off and not use it to quantify it. So we would make it look worse than it actually is. So between the baseline and this bony roof line, we measure the alpha angle. The cartilage roof line, for this line, the turning point is now relevant because we've learned as the concavity turns into convexity, the bony roof now loses contact with the femoral head. So this is where our bony coverage ends and where the cartilage cover begins. So the turning point is the first point to draw a cartilage roof line, and our second point is the center of the labrum. Not the top, not the bottom of the labrum, not the tip of the labrum, the center of the echo of the labrum. So this is our cartilage roof line, and this quantifies the cartilaginous coverage. So to summarize, the alpha angle is the angle between the baseline and the bony roof line and evaluates the bony socket. The beta angle is the angle that we measure between the baseline and the cartilage roof line, and this evaluates the cartilage roof. Of note, these 3 lines do usually not cross in one point. It is a very, very rare exception if you have very angular, very mature hip joint where the turning point equals this the most distal part or outline of the bone. Only in this case do these three lines cross in one point. Otherwise, as you can see in this picture, they don't. So alpha angle, beta angle. If we now draw those lines, just to emphasize this on a slice, anatomical slice, we can see here the bony roof line, the baseline outlining the center of the bony roof. That's the weight-bearing area. Our bone, the bony roof line, just outlining essentially the echo of the bone, and the cartilage roof line where the bone loses contact to the femoral head in the turning point through the center of the labrum. So our bony coverage, our cartilage coverage. Again, only measure hips if they're centered and in the standard plane. So we want to see the lower limb, the plane, and labrum visible in a centered hip. And we do not measure type 3 and type 4 hips. Example, here we have a decentered hip. Do we measure? We can't measure because we don't have our lower limb clearly visible, and we are here in a posterior plane. We've explained that the hip is moving posterior during the dislocation process. On the right side of the screen, you can see a type 4 hip. Again, of course, we have the labrum above the turning point. Also here, we're not in a standard plane. We must not measure those hips. Now, in this case, we actually have a centered hip, so we should be able to measure, but it does not fulfill our second checklist. So this is an anterior plane. So we have our lower limb here and we have our labrum here, but our plane is not straight. On the right side, again, we have a centered hip. The labrum is below the turning point, but in this case, we have a posterior cut. So again, we're not in a standard plane. We're not allowed to measure this picture. So if we now plot the alpha angles on a straight line, like in the sonometer, which is a ruler that we use and also distribute in our courses, we have three large subdivisions. We have the type 1 hips that are the mature hips. We have the type 2A and B hips, which are the immature hips depending on age. The type 2C hips, which are also type 2s, they're still centered hips and they're stable hips. But they are the critical hips. So their bony roof is here so bad that those hips tend to also go on to be dislocated. So the cartilage, which is mainly covering or providing coverage for those hips, can be deformed. And then this hip can turn into a type 3 and 4 hip, a dislocated hip. So in a type 1 hip, we have an alpha angle that's 60 degrees or more. These are the mature hips, any age. The type 2 hips have an alpha range between 43 and 59 degrees. We differentiate between the type 2AB, so the immature hips above 50 degrees, so 50 to 59 degrees. The only difference here, whether we call it pathological or not, is the age. So an alpha angle between 50 and 59 under the age of 12 weeks is normal for this age. So this is not a dysplastic hip, it's just an immature hip and requires a follow-up, but not treatment. Only once these babies have turned 3 weeks and still have not arrived at the 60-degree angle are these hips pathological, dysplastic, and would require treatment. The type 2C hips, as we heard already, 43 to 49 degrees, very poor bony coverage, mainly coverage provided by the cartilage. The femoral head can be displaced, it can be dislocated. So these are dysplastic hips and called pathological at any age. Why do we treat the type 2As? 3 weeks of age. We can see that on the maturation curve. When we plot the alpha angle in a longitudinal studies that has been done here from 0 to 12 months of age, then we can see if by 3 months they have not reached the 60-degree stage, they are unlikely to develop normally and might remain dysplastic and cause problems later on in adulthood. one quick differentiation between the type 2C and type D hip. So a hip that has an alpha angle between 43 and 49 and is a centered hip versus the same alpha angle in a decentered hip. The difference here, as we can see here, this is a bad or deficient bony roof that can have a cartilage coverage with the hip being centered, or the cartilage can be displaced because it is soft and the labrum moves above the turning point and is then a decentered hip. So this is the difference between a type 2C and type 2 hip. D hip. So this is all covered in a lot of detail in the courses, and I don't want to go too much into detail here, but just so to clarify what the differences are here. So with our measurements, we can differentiate between the normal or mature hips. We can differentiate the immature hip depending on age. We can differentiate between those hips that are so dysplastic that they are abnormal at any age. We can also differentiate those hips that have a very dysplastic acetabulum, whether they are centering or decentering, or whether they're called unstable by measuring the beta angles. And at this critical point of 77 degrees, they might be decentered as the type 3s and 4s. So that's a lot of information, and as I say, this will be covered in a lot of detail with a lot of practice on a course. Happy to answer any questions if you have any.
Thank you, Claudia. Yeah, can you hear me?
Yes.
Hello?
Yes, we can hear you.
Yeah, I'm audible. Hello?
Yes, you are.
Can you
Sandeep.
hear me? Yeah,
Yes, we
sorry.
can hear you.
Yes,
Yeah, sir.
Sandeep,
So
we can hear
Claudia,
you.
that was really a lot of information. And as you said, unless you do the practicals, it's really difficult to understand the type 2C and the D hips. But for the general people who are attending this for the first time, I guess what can we say as a generalization that if your bony roof angles are above 60, you're probably safe.
Absolutely.
Because if they are looking at a simple report given by somebody, the pediatric orthopedic surgeon should be reasonably confident that the hip is well developed and stable if alpha angle above 60.
Absolutely. I think
Right.
what is important is that in the report, the description is also present. So you
Yes.
saw that the hip is actually a centered hip, etc., before you start measuring alpha angles. But absolutely, if it's correctly measured, alpha over 60 is definitely safe.
And if your cartilaginous roof angles are not maturing by 12 months, we are looking at probably stable hip but residual acetabular dysplasia.
So the beta angle, so the cartilage roof, as the hip matures and you have more and more bony coverage, the cartilage roof becomes shorter and shorter. So in a type 1 hip, the cartilage roof angle has more sort of a scientific importance, I'd say. But it is really important to know that the cartilage roof or the beta angle makes a difference if the bony roof is at a critical stage. So if you have a poor bony roof, the cartilage angle does actually tell you whether the hip is decentered or centered. That's where the differentiation between the stable and unstable also comes into it on a sonographic picture or in your sonographic examination. So the maturity of the beta angle is not something that we would measure. Yeah, and it does change obviously over age as the cartilage cover becomes shorter and you have larger bony cover, but the measurement of it is not going to be important in terms of maturation.
So the beta angle does not give you direct correlation with maturation. Is that what you're trying to say?
Okay. Mm-hmm.
Okay. I guess there's a question from Thomas. Thomas, you can unmute and ask since you are on the group. Thomas, are you there? Yeah.
Yeah. So I was just wondering. Claudia showed a graph, which showed that 3 months it matures or something. I didn't get that. So for our Indian subcontinent, we are looking at X-rays to be one of the options to treat these hips. So the later we start treating, the better is what I gather. So if 3 months is an okay period to start treatment, in your opinion, or?
So I sort of briefly showed this maturation curve. So what we know is that in the first 12 weeks of age, there is a lot of remodeling potential in the acetabulum. After 3 months, that starts to plateau off. Yeah. So once you have a pathological hip and you center that hip at this age, it is less likely to mature because the remodeling potential is not as good.
Okay. So it's less likely.
So you're late. That means you're late.
Exactly.
You want to diagnose by 6 weeks of life, and you definitely want to try to finish your treatment by 12 weeks of life. It's those first 3 months you want to be in treatment. You don't want to start after 3 months because you've lost that steep curve of improvement. Yeah.
Okay. And then the papers that are published about Pavlikana's success rate, right? So after 3-4 months, that success rate goes down steeply.
Okay. And one more question is whether to treat at 2B stage or 3. Some recent literature said that after 3, it's okay to treat, but initially it was 2B. What is the best thing in your opinion?
I think we've got a talk on treatment. Maybe Claire will cover that, and there's treatment based on the ultrasound types. Yeah.
Okay.
All right. I guess we'll move on then. Again, the next talk is by Claudia again. Are all hip ultrasound methods the same? Why are they not the same? And why do you choose graph method? I'm sure that Bhushan and others will have some questions about the same.
So it seems, sorry, I meant to quickly open that talk. It seems that it has closed itself. Apologies. Show here.
That's fine. While Claudia is doing that, I think, Sandeep, the questions on treatment, depending on which part of the world you're practicing in, you still want to try and get the diagnosis done as early as possible and treatment started as early as possible. So I don't think if you've got a diagnosis, you should ever delay starting treatment for the baby. Okay, sorry, Claudia's got her slides up.
Oh, let me just go on. Okay, can you see that in full screen mode?
Yes, it's perfect.
Brilliant. So why the graph method? So just to briefly explain my personal experience. So I've trained in Austria. That's where I'm from originally. I moved to the UK in 2004. So more than 20 years ago during my training. And I've had exposure directly and personally to both ultrasound methods and to also to screening systems. And also in my hospital, sort of the radiology department in some of the sites continues to use the 50-50 method. So I'm not just talking in theory, I also talk from experience. And in my department, we have conducted a sort of a brief literature review, which I'm going to also show and show results of. So it's not just an opinion or not just to say the graph method is better, full stop. There reasons for and against. I'm going to just try not to convince you, but to just try and put it out there and compare what has also been published in the literature. So when in our literature review, we concentrated just on the most widely used ultrasound techniques. So the graph technique, the Suzuki technique, the Harke technique, and the Terjesen technique or Morin technique. So briefly, graph technique originated in Austria, is used pretty much in Central Europe and also Mongolia. The Suzuki technique originated in Japan. And as we heard from a colleague, ICODE colleague from Japan, is mainly used actually in that hospital apparently, where Suzuki is practicing. The Harke technique originated in the United States and is widely used there. The Terjesen technique or Morin technique, so the 50-50 technique, if I can just widely explained that way, originated in Norway, very much used in Scandinavia, but also in big parts of the UK. So to describe those methods a bit more in detail, so we can understand what's the pro and cons from these methods. So the graph methods, as we heard in a lot of detail already, is very, very standardized. So not just how to analyze the picture in a standard plane is standardized, but also the screening process. So we have a cradle, we have a sono guide, which are recommended to produce standardized pictures, but there are also great guidelines on how to set up your examination room, how sort of what instructions to give to the mother. The whole technique is essentially aiming to make this ultrasound examination as quick as possible, because we're essentially racing against time, because there's just so long that this baby is going to keep still and allow you to move your ultrasound probe on it. And as soon as the baby starts to move or to cry, you're pretty much lost, because you won't be able to see all these structures very nicely that you want to see. So very, very standardized approach from the setup to the picture quality and measurements, description, etc. So we've heard the checklists, we heard about the standard plane and measurement. So when we're looking at the literature, it was very important to establish whether authors are actually truly using the graph method. So these are just a couple of examples from papers published quoting to use the graph method. Now, as we have heard in the previous talks, both of those pictures do not really represent the graph method. You can see here on the left side, although the plane is not too bad, but we are missing vital anatomic structures, the same on the right side. So we don't clearly see the structures we need to see, and also those measurement lines are crossing in one line, so we're not measuring here through the turning point. These pictures are not representing the graph technique. So that's, I think, a very, very important message when you're coming to evaluate literature. Are these papers really based on the graph method or the original method? We know now that we have to have all these landmarks visible on a picture. We need to be in a standard plane before we start measuring. And if we're measuring, it's very rarely that those lines cross in one point. So also those measurements have to be performed correctly before we can say that the graph method is used. We have the 4 hip types, as you heard. We have the normal hips, we have the dysplastic hips, and we have the dislocated hips that we describe. Important because it's standardized, and with my long explanation about the types and about measurements, we know that the dysplastic sort of group of hips that are centered still, but and also stable, it's important that you take on board that this gray area, which is in other techniques not clearly identified, or what the trouble comes into making a call on whether a treatment is initiated or not, because in young babies or before the age of 2 weeks or 6 weeks, you get overtreatment, is because you don't take age into account when you're looking at the anatomy. In the graph classification, you do that. So you have not a gray area. You can subdivide this dysplastic hip. We have our ultrasound measurements in the graph technique, again, as we heard, and this type 2 area we can subdivide into those that are just immature depending on age, and those that have a true dysplasia depending on age, the type 2Bs, and those that are dysplastic at any age. So even if you have a 1-day-old baby and you would perform a hip ultrasound, you can definitely diagnose a dislocated hip, and you can say this is a dysplastic hip regardless of age, because the bony coverage is so poor. And you can say, well, actually they are not a type 1 yet, they don't have an alpha angle of 60 yet, but they're in an area that according to age they are still normal, they're just immature and only have to be followed up and not treated. No gray zones. We've talked about the maturation curve, so we also know how the alpha angle develops depending on age, which helps us with our treatment decisions. Now, in comparison to the graph method now, I'm also describing the other methods. So I'll start off with the Suzuki method, where both hips are examined simultaneously. So we have an anterior approach. There are lines drawn as well. We have a P line, which outlines the front of the os pubis on both sides. We have an E line, which sort of runs from the lateral part of the os pubis, and the femoral head location is now assessed in relation to these two lines. It should be behind the P line, and it should cross the E line to be called centered or normal. So what you differentiate with this method essentially is if the hip is in joint or if it is out of joint. It has a very high sensitivity and is useful for certain scenarios as well. So to show what on the Suzuki method is visualized, it's comparable maybe to an MRI scan. Here in a coronal plane, you see whether the femoral head is in joint, like here on the right hip, or on the left hip, whether it is dislocated out of the joint. So it loses the position in comparison to these two lines that have been drawn. The next method I'm going to describe is the Hake method, originated in the States. Theodor Hake has published it in 1984. So with this method, the patient is in a supine position. We have static and dynamic views in a frontal as well as in a transverse plane. And it is mainly a qualitative description with measurements being not mandatory, but can be done. So they are optional. Both the femoral head coverage or also alpha angle measurements can be used. And for femoral head coverage, it is considered normal if the coverage is more than 57% in patient under the age of 9 to 12 months. The differentiation in this method is normal, sublux, slightly dislocated, or dislocated. Just to show what views are obtained, we have the transverse view. There's sort of this sunflower appearance, again compared with an MRI scan here. And we have the coronal view, similar to the graph method, with our ilium, our femoral head visible. You don't have obviously those landmarks or these checklists that are required in the graph method, and you check for the coverage of the femoral head. Which brings me to the Thiersen or Morin method, originated in Norway and published in 1989. In this method, we also have the coronal view, as you can see here, the picture, baby lying in supine position, the transducer in the coronal view position. And what is measured with this method is the bony rim percentage of femoral head coverage in percent. So the femoral head coverage should be more than 50% with this method. What is differentiated is normal, dysplastic, subluxed, and dislocated. And what is published in the original paper is that the mean normal in girls is 54% and in boys 56%, with the lower limit of normal around 45% on average. So this is more comparable to a migration index that you would measure in a neuromuscular hip. So to describe the method a little bit more in detail. So again, as I said, similar to the migration percentage, what you're measuring is the diameter of the femoral head versus the coverage, the bony of the bony roof. So it's the small d to large d measurements expressed as a percentage. So important to say is if a hip is now subluxed out of the hip joint, it is possible if you measure these two areas, so the diameter of the femoral head versus the depth of the acetabulum, that you get 50-50 between the depth of the acetabulum and the uncovered part of the femoral head, even in subluxed hip. So it's important that what was later described and revised in that original technique is that you measure not small d to large d distances, but d asterisk, which is the part of the femoral head that is still covered by the acetabulum versus the diameter of the femoral head in percentage again. So what is with this technique considered as normal is more than 50% coverage, 40 to 49% is possible dysplasia, 10 to 39% subluxation, and below 10% dislocation. Now, if we have the ossific nucleus present, the Tersen method also uses the lateral head distance, which is an expression of the uncovered part of the ossific nucleus. And that can have a minus sign in normal hips. So it is essentially similar to the center edge angle in a way. The Tersen method also has an instability test where the hip is adducted and pushed in a similar way as in the Barlow maneuver. And of note is that with this method, in a newborn, the femoral head coverage can be 35% or less with this flexion adduction stress views. And what is checked is if the femoral head moves laterally for more than 3 millimeters. Now, the issues we have is that the ossific nucleus, as we heard, is not always in the center of the femoral head. And also, we heard about the way that this picture is actually produced with ultrasound. So the ultrasound waves are being reflected at the bony surface, which makes the femoral head appear more lateral than it actually is. And the stress views are difficult to interpret in very young babies due to physiological laxity in newborns because of maternal hormones, which only sort of lose effect after around 6 weeks. So what are the problems with femoral head coverage? Or bony rim percentage is the assumption, as I said, that the femoral head is round and the ossific nucleus is in the center. We don't have a standard plane in the Tersen technique, and it doesn't take age into account. So we have this slightly gray area of dysplasia, which is not correlated to age, or the anatomy is not correlated in age to age in this technique. So in terms of the femoral head not being round, you don't have to take our word for it. It has been nicely published in a few papers. I'm mentioning 2 here. This paper, published in 2010, has examined 37 hips during open reduction in DDH. And this group has calculated a sphericity score. And you can see it is very, very rarely, almost 100%, the majority of hips have an ellipsoid shape rather than being spheric. Another article looking actually at adult hips in order to get a personalized model of a femoral head prosthesis. So was the aim of these studies. It's a CT-based study, and they also found that the femoral head is not actually a sphere, it's a fitted ellipsoid. So where's the center of a non-sphere object? If the femoral head is not round, as we know, how can we precisely measure the femoral head coverage? So the problem is it very much depends on which position the head is positioned in the acetabulum and on your ultrasound picture. As you rotate the femoral head, a different amount of this or portion of the femoral head will be covered by a bony acetabulum, which doesn't change shape. We were talking about the standard plane and tilting errors. So with tilting errors, which you can recognize with your graph method, we get different amount of bony coverage. So one of the reasons for tilting errors is an artifact. So ultrasound waves travel at different speeds in different structures. So in soft tissue, in muscle, it travels at different speed in comparison to joint fluid, in comparison to cartilage, in comparison to bone. So you get artifacts as well as different structures, especially bony structures, obscuring your view. And therefore, all these 3 hips here on this slide, we can see an alpha angle measured at 65 degrees, 55 degrees, or 49 degrees, are actually the same hip. hip. And this is what tilting errors can actually cause. You get false positives, but it doesn't only apply to the graph method, it also applies to your 50-50 method. You keep in mind this is the same hip. So depending on tilting errors, you can make a hip very easily look pathological when it is actually not. So in our review, we've looked at these 4 main techniques. We wanted to identify which technique is most effective in diagnosing patients with hip dysplasia, but also helps us make a decision on treatment. So we've come down to 8 articles that are comparative reviews, comparing Graf versus Thiersen versus Hake versus Suzuki, and also comparing all 3 different methods. All of these papers were quality checked. So when we compare those 4 methods, the studies that were included, one of those studies preferred the Thiersen method, so the 50-50 method. The others all preferred the Graf method as being more useful in determining whether a hip is dysplastic or dislocated or normal. So the group that preferred the Thiersen method preferred it because it was thought to be easier, and they felt that Graf was overdiagnosing. Having to say that in this paper that Graf 2A hips, which are immature but not abnormal, were classified in pathological, which explains why there potentially was overdiagnosis. In the other studies, just to quote, that Graf results are related better to the incidence of hip dysplasia in Central Europe, and that the Thiersen method overdiagnosed in comparison to the Graf method, and they found better results in their cohort with the Graf method. Another study suggesting better results, better matching the frequency of DDH. One study found that the femoral head coverage wasn't useful for screening, and for screening test, Graf was superior. This group, DSSR, found that Graf was superior to other techniques, so they compared several, Hake and Suzuki as well, and that with this method DDH cannot be missed. Joshua found that Graf was reliable, especially if these examiners were trained for the method, adequately trained, and they found Hake had a useful limited in their patient cohort. Fanedal found that Hake correlated with Graf, especially in the normal and abnormal settings, but they found that the femoral head coverage showed significant difference according to the hip position, which we already explained in terms of an ellipsoid, and the way it is located in the hip joint will change your percentage coverage. Diaz et al. Found that Graf was more useful for screening, again as a screening test, but they found that Suzuki was helpful in assessing the hip position in a harness or abduction brace. In addition to our literature review, there's also been a meta-analysis published in 2022 that compared Graf versus other methods. So they used all the methods that are available and used, not just the main method. And their conclusion was that all the techniques demonstrated at least one rate, so in sensibility and specificity, lower than the 9% when compared to the Graf method. They found that the second best after the Graf method was the Morin technique if it was used in a 3-pattern classification. Then it had a very high sensitivity, so you couldn't miss any dislocations or dysplastic hips. But this in this 3-pattern classification uses 58% coverage as the limit of normal. So all those techniques that were evaluated in this review, just plotted here, the Morin technique with 2 categories, Morin technique in 3 categories, the Suzuki technique, Thiersen technique, the Treguier technique, that's the pubofemoral distance. They found different papers using different distances as the limit to normal, and also different positions of the baby, of the hip when it the hip is in flexion or in neutral. They also evaluated the Hake, the Bogeston, the stress test technique, and the Rosenthal technique. So their final conclusion was that the Morin technique can be used for screening areas that do not have the professional with a satisfactory expertise to perform the graft method, but in those circumstances where the Morin technique defines an unhealthy hip, the patient should be forwarded to a reference location for a more specific test, which is the graft method. So in conclusion, with our systematic literature review and also taking the meta-analysis into account, the graft technique was the preferred method in a majority of studies. It's because it's standardized, it has clear checklists, so it means it's auditable, and we have a standard plane that can be checked by anyone, and a hip ultrasound picture can be evaluated and diagnosed even if you haven't been present at the time of scanning. It classifies the acetabular dysplasia. You don't have any gray zones, and you can very clearly define whether hip is normal or abnormal or just immature, and it will develop as the baby is getting older. It takes the anatomy into account according to age, which is very important for your treatment decisions. And what we also know on large studies, depending on geographical location, that if it is used appropriately and in a universal screening model, then you have fewer follow-ups and a lower treatment rate in comparison to the literature. So these are my references. Thank you very much. Happy to answer any questions and start the discussion.
It was really exhaustive, Claudia. Thank you very much for that. Are there any questions? Bhushan, Alaric. Alaric has joined us, so let's welcome Alaric, our President, Pediatric Orthopaedic Society of India.
Hello, hi friends. Good to see all of you. Sorry I joined a bit late, but some great talks already happening, and thank you so much for sharing all your expertise.
Thanks, Alaric.
So Thomas or Bhushan, do you have any questions regarding Claudia's talk regarding the graft technique being the gold standard, so as to say? We are fortunate that we don't know any other technique, so I guess we are on safe grounds.
So not a question. No, sorry. I think Dr. Thomas can, then I'll speak.
Yeah. Just that I trained at DuPont where the Haki method was done, and they sort of say in the dynamic, because it's a dynamic method, it sort of helps you to decide between the sort of borderline stable ones. I don't know what does Claudia or others feel about that sort of an advantage over the static method.
So the stability test is really a clinical test, right? And you essentially extending that clinical test by looking at the ultrasound picture at the time as you stress. So we said this is where the age limit in a way comes into it. And this is why with this method, you don't want to screen those babies or ultrasound those babies too early, because it is, if you have this still in impact of these maternal hormones, and you have this physiological joint laxity in the very young babies, it can be false positive. Yeah, because you are just checking if you are able to move the femoral head slightly out of the joint. You don't take the coverage into account, which is a fixed way, right? That doesn't, you have a bony coverage, doesn't matter what age the baby is. So the dynamic test is a necessity because you are supposed not taking sort of, these fixed parameters into account. It is a dynamic, as you say, a dynamic measure. We're using it in one of our sites in the hospital I work in, and I'm used to both methods. And I have to say, the difficulties we have, so you can differentiate the completely normal ones, right? And luckily, the majority of baby hips are normal. Fine. You can also say, well, this hip is clearly dislocated. The problem we are having is with the dysplastic ones. And yes, stability test. Again, if they're very young, that's not very reliable. And we have the problem that it very much depends who is performing the ultrasound scan. So we have very experienced radiologists, fantastic, and actually usually her pictures are pretty much in the standard plane, which helps us using the graph technique, our description, etc. But if the next session somebody else is performing the ultrasound, they might not get as good pictures. You suddenly have the problem, you have treated the hip maybe, based on one ultrasonographer and based on these dynamic views, and then the baby comes back 2 weeks later and it is an absolutely normal hip because somebody else is doing the scans. So it is more objective, I'd say. The nice thing with the graph method, I don't have to be there. Somebody can send me the scan based on that.
Sure.
Bhushan, I think you were asking something.
Yeah. So just a comment, I would kind of echo what Dr. Claudia has just mentioned. And I mean, working at Southampton Children's, we used to use the Harkey's method there as well. And although all the consultants kind of had a consensus as to which hips they would treat versus which hips they would kind of tend to observe. But as a person who was just trying to learn this method, I always kind of probably was always on the wrong side. And I would always wonder why this hip looks normal to them, what looks hip looks dysplastic to them, what looks normal to me. But then I think using the graph angles when you're learning, you have a much more objective method of trying to classify whether hips are normal or not, rather than subjectively assigning a grade of dysplasia to the hips just based on the appearance on the ultrasound.
Another problem we have with the 50-50 method in our site is treatment, right? So once you start treatment, when do you finish treatment? So we had hips that started to become 50-50 covered and treatment was finished. And then it turned out to be dysplastic later on. And, when you have the x-ray, they were actually lateralizing again. So treatment was finished too early because the 50-50 method isn't quite adequate enough to say that the hip has now matured enough, not using your alpha angle and your description. So you might overlook a type 2C hip, for example. So you have a hip that responds well to treatment, but to actually make a very, again, objective decision when treatment is stopped is more difficult.
Yeah, very good point.
Just a comment from me, Sandeep, if you got 2 minutes.
Yeah.
So Bhushan, I agree with what you said. When I started as a consultant in 99 in Cardiff, we used the Harkey method for about 3 or 4 years. And then we had some late presentations for hips that we had previously, just eyeballed and called normal. And that's why we changed to the graph method, because as you said, it is more objective. And Thomas, just to your comment, when I was a trainee, the dynamic, the DCP plate or the dynamic, plate that Synthesis had come out was just around. And certainly as trainees, we all thought everything that was dynamic was somehow better than anything that was static. Okay. That was our normal association with the term dynamic. So I'm just giving you a simple example. Let's say screening a baby hip is like probably running an accident emergency department, right? You've got a child who's got an elbow fracture. And if you want to run it with a radiographer and your radiologist at home, every kid who comes with an elbow fracture, you're going to get an AP and lateral view. And then you make your decision based on that. So that's your static method. If you try to run an A&E and said, every elbow fracture that came in, I want an image intensifier and I want to actively screen it, push it, pull it. I want to see every possible angle. I'm sure you'd pick up a couple of tiny extra fractures that you wouldn't have seen on the standard views. But it would be impossible to run an A&E department if you said every baby had to have a dynamic test. So you can use the static test to make your screening decisions. And then if you had the odd case where you particularly wanted to do a dynamic test, that's fine. You can add it. The system allows it. But you don't have to do it for, remember, only 1 in 1,000 babies is going to be abnormal. You don't want to do a dynamic test on 999 babies to find that one. So when you suspect one, definitely, if you want, I have no objection. You add the dynamic test, but that doesn't need to be there for the initial screening test, just to make it easy and simple for us to implement a system that you can use for universal screening.
I think with that, Sandeep, let's move on to your next talk. Clinical, universal, or selective screening. What are we looking at?
Okay, so give me 2 minutes while I share my screen and I'll just give you our view. Need to just tell me, Sandeep, if you can see the...
Yes.
You can see, but I'm trying to just get the...
Full screen, yeah.
Okay.
Yeah.
Have you got
All
the
good.
front picture
Yes.
on? Okay,
Yes.
perfect. Okay.
Yes, good. Yeah.
So thanks. So I'll try and keep this brief. And I'm talking about DDH screening and a little bit about history of, what we've done so far and what's currently happening. So aim of hip screening really for any healthcare system is to reduce the incidence of late presenting DDH. Yeah, and at the same time, we don't want to cause any harm either with overtreatment or avascular necrosis. Those are our aims of hip screening. WHO has criteria, you will all be aware of these, and DDH fits these criteria because we do have a method to pick these conditions early. And we know that if we treat it early, we can change the natural history. So, we satisfy the criteria to say that, DDH should be screened for. So these are really, the clinical examination and ultrasound are the two methods of screening. So with clinical examination, why do we fail? Do we fail because our clinical examination technique's not appropriate? Is it that the person doing it is not experienced enough? Or is it simply because the type 2C has no clinical signs? So it doesn't matter how experienced you are or you've done it for 40 years, you will still not find all your DDH at birth because a type 2C hip has no clinical signs. So here's some literature where clinical examination was assessed, and they really make you wonder, why we do the clinical examination. So 93% of hips that clinically were felt to be query abnormal sublux were normal with the graph method. Equally, on the other way, 26% that were clinically thought to be dislocated were normal on this scan. So clinical examination is not reliable. It's got issues with who's doing it, what the experience is, and even in the most experienced hands, it won't be reliable because type 2C hips have no clinical signs at birth. We know that all methods of screening will reduce late presentations, but it's just a question of to what degree they would reduce. So clinical examination would reduce some. So I'm not saying you should not do clinical examination. Then we're looking at selective ultrasound screening versus universal ultrasound screening. So orthopedic surgeons spend a lot of time discussing which risk factors you should screen for, but some of this information would make you realize why all those discussions we have are not of great value if our eventual aim is to prevent all late presenting DDH. So in this paper from Blackburn, only 30% of their dislocated hips had any risk factors. That means even if you screen for every known risk factor in that group, you would have missed 70% of those dislocated hips. This was a paper from Great Ormond Street, and in their group, where they only found only 12% of the hips they were doing open reductions on had risk factors for selective screening. So their current screening program was basically failing to eliminate their late DDH presentation. This was just another bit of literature to show that if you treat babies and start treatment early, that's below 6 weeks of age, 83% success rate with Pavlik harness or splintage. If you start treatment after 10 months of age, then the chance of open reduction becomes significantly more. And we know that early simple treatment is better than late complex treatment. I think this was a paper from Southampton. So Bhushan, this is probably from the center you worked in, which showed that across 40 years of selective screening, we had made no difference to the rate of surgery for DDH. So our selective screening wasn't changing anything significant. Universal screening, we'll talk a little bit about that. And there was a small pilot project for universal screening done in the UK by John Clegg. And he had shown while he was working that he started with selective screening in this group, and then he switched to universal screening. And not only showed that the late presenting DDH rate was almost zero, but even financially for that city that he was working in Coventry, it was worth it. But politically, after he retired, they did not continue it, and nor was it extended to any other part of the UK, which was a shame. So here's a good example. When he was doing universal screening in the period between 2005 and 2008, the late diagnosis rate was 0.02%. And as soon as he retired, I think in 2008, in the next 3 years, late diagnosis jumped in the same period for a similar population to almost 10 times. This was a paper from Norway, which tried to look at, universal screening versus selective screening. They had 2 groups similarly matched. In the universal screening, they had one late presentation, and the paper clearly says this late presentation only happened because that child didn't turn up for the screening program. And in the other group where they did selective screening, they had 5 dislocations. I would have thought, group 1 had done better than 2, but in their conclusions, they decided that both were similar. So that was a bit odd. This is the Austrian HIP universal screening. Austria has universal screening. They compared 2 periods of time when Austria didn't have universal screening and had universal screening, and clearly showed that there was 76% reduction in their surgical intervention. And surgical intervention was classed as, I think, open reduction or anything more than open reduction. Again, here, rate of major surgery, if you compare different countries, Ireland, United Kingdom, Australia all have only clinical screening or selective ultrasound screening, and their percentage of open reductions or more for any intervention per 1,000 live births is about 0.3 in the UK, whereas in countries which you have universal screening, they are 10-fold lower, so it's 0.04 or 0.09. Some people who criticize universal screening would say, oh, you might overtreat and cause AVN. There's enough literature to show that when you use this brace correctly, it does not increase AVN. And I think this is the most impressive recent literature I've come across, where Mongolia has a universal screening program. It's set up by 2 Swiss pediatricians who, made it their passion to run this, and they're running it very, very successfully with very good results using the graph method to screen every newborn baby in Mongolia. And more recent current concept review said, what we've been doing for the last 30 or 40 years is not reducing our late DDH rate. So even in the Western world, if you want to eliminate DDH, late presenting DDH, then you have to move to universal screening. This was another paper from Southampton, and when this was picked up by our, the local news or the media, and they have headlines like, newborn hip checks with clinical and ultrasound have made no difference to late diagnosis over 30 years, then more people take notice than when we write them in academic papers. So certainly our aim is to try and get universal screening for Wales. We're still away from getting there, but we'll continue to work towards it. So there we are. Thank you. I'm going to stop sharing and happy to take any questions.
Just got one question, Sandeep. It was
Sure.
a nice
Go ahead.
thing. The problem in India is the cost involved, right? And the lack of availability of ultrasound, good trained ultrasound sonologists, whether it be radiologists or even pediatric orthopedicians to do screening. So in that sort of situation, we have to do selective screening, right? We can't universal is out of question.
I absolutely agree with you. Okay. Yeah. Even if you gave me all the money in the world today and said, oh, tomorrow morning, here's all the money you want, provide a universal screening program, you can't do that. It's not just the shortage of funds. You have to train enough people to be able to provide such a service. So any service which starts will first have to start selective screening, get better at the method you decide to use, try and standardize that method, try and maintain the quality of that method, and then at some point in the future, you can go to universal screening, okay? Yeah. And the other way to look at it is I'm talking first to the UK, and you can tell me what happens in India. In the UK, every pregnancy has 3 ultrasound scans at the minimum, okay? And I'm sure it's pretty similar in India as well. So the ultrasound machine still exists. All you have to really think of as a step is, instead of having 3 scans per pregnancy, you will now need 4 scans per pregnancy. It's not as if the country has to go buy thousands of extra ultrasound machines. They already exist. You just have to train the people who provide the antenatal care and give you 3 scans. to be trained, or the radiologist or whoever's going to do the scan, to train to do one more. So it's not such a big step as you might otherwise think. Yeah.
I agree. I've tried to talk to the neonatologist or the senior gynecologist, as we say, the baby factories in India, and tried to sell them this idea that as it is you send blood for G6PD and genetic disorders, how about one scan on the baby which is born, at least in high risk, all your breech, all your firstborn, all your females, something like that. But I think awareness is where we need to work at, and training, like we said. So hopefully we'll get there.
I agree,
I think
Sandeep.
we'll
I think,
move on.
yeah.
Yeah, sorry.
It's awareness
We'll
of
discuss.
the family as well. I mean, you need
Yes.
public
So
education.
I think we'll finish with Claire's talk on treatment options, and then we'll have a group discussion on the way ahead, led by Alaric, on this issue.
Okay. Can you see that?
Yes.
Okay, so
Yes.
okay, great. So we talked about the merits of using ultrasound as a screening method in hip dysplasia. But another thing about the graph method is now you can have a reproducible check on your treatment methodology. And I think, again, if you look at the worldwide literature on the early treatment of DDH, not late treatment now, that's a whole host of controversy in itself. But the early DDH treatment, it is vastly different throughout the world, no matter what the literature you look at. And all of a sudden, if you understand how to do a good ultrasound scan, all of a sudden you can standardize your treatment methodology and make it bespoke to the child. So what are the goals of treatment? Well, to reverse the pathoanatomical deformity of that hip joint. Again, come in early so you can make the full use of the own biological potential of that hip joint. We use it in talipes, we use it in serial casting, we use it in all aspects of pediatric orthopedics. Why are we afraid to use the biological potential of this hip? Why are we waiting, and what are we waiting for? And again, avoid damage to the growth plate. So you have to understand the principles of what you're doing, why you're doing it, and how to do it in order to avoid damage to that developing. And we're all afraid of this concept of avascular necrosis or proximal femoral growth disturbance, whatever you want to call it. But again, sometimes that is inevitable. However, if you understand the principles, you can limit the impact that you're going to have on that femoral head. And this is what we are trying to do. We are trying to get a hip that is dislocated, potentially, or even dysplastic, and place it back into the correct space. So those forces within that hip joint are restored. Therefore, the biological environment within that hip is restored to allow the body to do what the body knows best and start to develop and grow. And we want to make full use of the ossification potential, and we've already seen this maturation curve of graph. And again, the point at which this curve is steepest is the point at which the biological potential of that growing hip is at its greatest. And you can see that between 8 and 12 weeks, it starts to probably take off around about 6 weeks. You've got this window of biologically rich opportunity. And then after about 4 months, it starts to plateau. So early treatment allows you to access that early biological potential. So you want to be able to get these babies, you want to be able to scan these babies, and you want to institute a treatment pretty much as early as you can. But again, what you've heard is what you also want to do is avoid any over-treatment. And again, over-treatment is costly, over-treatment can have its own morbidity, and it's not very nice for the babies and the family to have either unnecessary or prolonged treatment if they don't require it. And again, avoid damage to the growth plate. And we've looked at the inside of the developing acetabulum. And these are, again, graph slides showing beautifully that histological growth plate. And we all know if you compress a growth plate, you don't get ossification. Again, here's my mouse, and you can see this cellular growth plate here is your ossification front. Eventually, if the hip is in the right place and the hip is under the correct forces, that ossification front will proceed to ossify the whole of this hyaline cartilage roof, leaving your labrum and a hyaline cartilage surface there. But if that has been compressed for a significant amount of time, then you're going to get microcellular damage to there. And who knows if that growth plate is going then to regrow and become active. And that's why sometimes we use this method, but we still see late dysplasia because you cannot see the microcellular damage at the time. So what we have and what the hip ultrasounds show us visibly is this continuum of a normal developing hip to a hip that's dislocated. And Sandeep has mentioned that, you know, the majority of these are clinically undetected. Oh, well, at best, we have 70% clinically detectable, even in expert hands. And I am sure all of us on this webinar have examined a hip, felt it was normal, and then got further investigations, and that hip has been out. So again, why are we bothering when we can just go straight to a reproducible standardized ultrasound? And again, what we will then have is a number of different types of hips, from normal to dysplastic to decentered, that can then guide our treatment. And again, we can think of it in the 3 essential steps. If you have a hip that is dislocated, it will need some sort of reduction. Once it is reduced, we need to hold it there for long enough in order for the stabilizing structures, for the hyaline cartilage roof to reconstitute, for the capsular laxity to shrink back, for the bone to start activating and reossifying its front, and so that then hip can go on to mature and resolve that existing dysplasia. And so classically in this system, in the type D hips, 3 and 4, they need some sort of way to be reduced back into the floor of that acetabulum to restore those forces. And again, if you're thinking about it in principles, it doesn't matter how you do it. The principle is the same. You can manually reduce it as you would do in an ortolani and then place them into a brace or some sort of Pavlik harness. You could do it via graduated traction into abduction, as akin to some of the Japanese and the French method. You can use other types of brace. You can do a closed reduction at under a general anesthetic. So the method is irrelevant. The principle is to get the center of that femoral head back into the acetabulum. And once it's there, you have to keep it there somehow. And again, in some hips, they have enough inherent stability that it'll stay there with good bracing techniques. If it doesn't, you could maybe put a hip spiker on in order to hold it a little bit more statically. And again, when we talk about, it's classically the Ds, 3s or 4 that need the retention after the reduction. And again, the other thing that is key in these hips is flexion. A lot of the time we look at abduction is important, but actually more and more we're getting to understand that actually flexion to 100 degrees, not beyond, is probably better because it directs those femoral heads deeper into the acetabulum rather than just abducting those hips. And again, as we've said before, Pavlik, any sort of splint or hip spiker can achieve that for you. And again, these two images are showing that on the left, if you just put that hip into abduction, you are not directing the center of that femoral head deep enough into the acetabulum. And then what you've got is almost point loading of that femoral head onto that acetabular edge. And you've all seen that the hyaline cartilage, it's soft, it's compressible, and that's when you end up getting, classically, your signs of avascular necrosis or proximal femoral growth disturbance. But again, if you just flex that hip up, as is on the right, you can come under the deformed hyaline cartilage roof and you can center that hip deeper into the acetabulum to restore the forces. And again, these are graphs, historical pictures showing the method that was described by Lorenz to put a baby in a hip spiker on the left into pure abduction. And again, the one on the right is where flexion to 90 or 100 degrees has been preferred. It still has an element of abduction, but you certainly do not need to put it in the severe ranges of abduction as you put on the left. And again, we all know that within the literature, abduction over 60 degrees is associated with higher rates of proximal femoral growth disturbance. And again, this is just a nice series of arthrograms in a child who failed Pavlik harness treatment, showing the very similar principles. So you have bilateral dislocated hips. This baby was 10 weeks old. She was taken for a closed reduction, an arthrogram. So there's the arthrogram showing fairly blunted hyaline cartilage roofs. There may be, there's no significant medial pooling, so we could get those hips in. And again, when you go back to change the hip spiker 4 weeks later, we do a repeat arthrogram because we want to see that that hyaline cartilage roof has reconstituted, the capsule has shrunk down, and again, the hip is sitting deeply within the hip. And this is, again, using the similar principles of reduction, retention. But this baby still has acetabular dysplasia in comparison to her peers. So this still needs a period of maturation thereafter. So once all the hips are held and reduced, then they just need to catch up with what is expected for the acetabular index or alpha angle, whatever you wanted to use for those children at that age. And again, usually we use the maturation principle in 3s and 4s that have been, and Ds that have been treated and retained, and then the 2Cs, 2Bs and 2A minus hips, again, that are not dislocated, but they need this period of stability to allow maturation. And again, the principles of the treatment are slightly different, and we'll talk about that. And remember, an alpha angle of 60 in a child who's 4 months old is not your end goal. An alpha angle of 60 is normal for a child of 6 weeks of age. So you then have to understand that you need to push that that maturation on so that you're confident that that acetabular maturation has occurred. And remember, if you're using graph or tonus, they are the congruent angles. So you can see that the pattern of maturation in graph and tonus is very similar. So what do you use? Well, in the UK, mostly it's the Pavlik method. And remember, Pavlik described the functional treatment of hips using what was then a leather harness. We now have cotton harnesses that are a little bit more comfortable. But what you need to do in the reduction phase is actually allow that dynamicity of the hips. You need to allow those legs to extend against those foot straps for the hip vectors to be centered deep in the acetabulum. So actually, when you've got a hip that is dislocated, you need to ensure that that Pavlik harness is in flexion. You must ensure that obviously those hips cannot dislocate and come into adduction, but you don't tighten up the posterior straps to keep that hip in abduction. You allow the baby to move those hips, and that hip gently will come down and reduce itself. Once that hip is reduced, then you have to make sure your Pavlik is tightened a little bit in order to stop that movement, because then that shear and micro movement is not good for maturation. You almost need to hold the hips a little bit more solidly during the maturation phase. And we know Pavlik harness is successful. I would argue it's not as successful in the type 4 hips. It is not as successful in the older age group. People who are who kind of want to argue against the graph method sometimes say, well, you know, you over-treat in a Pavlik harness because you sometimes will treat a 2A minus hip, which would, in some cases, by natural history will get better, but in other cases we have seen that they don't. And again, using time and being pragmatic, you can then choose to use a Pavlik harness in those cases. But some people will say, well, there's a risk of AVN. I can categorically say that if the Pavlik harness is used correctly, there is no evidence that you get proximal femoral growth disturbance in Pavlik harness use. We've looked at our own practice. We haven't had a case of AVN in 10 years. We have plenty of AVN in open surgical hips. Femoral nerve palsy, I'm sure you all know about. If a femoral nerve palsy happens, you take the baby out of the Pavlik, allow it for it to resolve. There are no cases in the literature of permanent femoral nerve palsy currently. I'm sure there's somebody will always create one in the future. And again, Pavlik disease, I think, is really quite a significant thing. We've already seen the histological appearance of that acetabulum. So you don't want to be compressing a femoral head against the posterior wall of that acetabular growth plate if you can help it. So again, good follow-up to ensure that this hip is improving is absolutely necessary when using your Pavlik harness. And again, once you've come out of the functional dynamic aspect of using the Pavlik, you can choose, if you want to go for a more static type of splint in the maturation period. And some of the literature says that, you know, if you fail to stabilize with the Pavlik, of course you can go on and use another splintage technique. But again, you need good follow-up. You need objective evidence that what you're instituting is being beneficial to that child and that child's hip. And if it is not, then you've got to think about doing something differently. And again, this is what you can achieve with a standardized approach utilizing the graph method. So we have a baby who presents with risk factors and no evidence of any clinical instability at 6 weeks. That left hip is a decentered hip. It's probably a type 4 hip and was placed at that point into a Pavlik harness. The Pavlik harness was made sure that we go for 100 degrees of flexion. It's not tightly applied. It's loose to allow that baby to kick so that hip can be centered deep within the acetabulum. And they get a call from our hip dysplasia nurse to ensure that they're not getting any problems. Baby's skin is good. They're moving their upper and lower limbs to make sure that they are coping with their baby in a Pavlik harness. And from some of our studies in the past, we know mums do really struggle with maintaining the harness. They take them off. They question why the baby has to have the treatment because the baby always appears completely normal. So you do have to spend some time counselling. And I can tell you, both myself and my paediatric orthopaedic colleagues have no time to counsel a mother. So getting a therapist or a nurse to do that job is absolutely beneficial. And now our nurse applies the Pavliks for us. They counsel. She is a port of call for families to give them a call if they're struggling. So you then come back 2 weeks later, you check that what you have instituted is beneficial to the child. Again, once that hip has reduced and we're able to retain it, we then go into the maturation phase, and the hip ultrasounds happen every 4 weeks. Now, at the 14-week stage in this baby, the alpha angle was 60 degrees on measurement. But again, at 60 degrees at 14 weeks is not quite enough in order to say that this is normal for age. And so you can see at the 18-week, again, there's slight asymmetry in the hips because we expect there to be, because the left hip was decentered, but the right hip was normal. And again, you see that the ossific nucleus is starting to develop in those hips. And once they've normalized, they're normal. They do not need weaning. They do not need nighttime bracing. They do not need any other type of hip support. And then we follow them up. If they're early at 6 months, then at walking age, and then at 4 to look for any signs of late dysplasia to make that decision if we need to do a pelvic osteotomy. And again, looking back at our 20-year data on early hip dysplasia and Pavlik harness treatment, the majority of these children, when they've successfully been treated in a Pavlik harness, are discharged at 4 years of age. And we don't follow them up looking at hip dysplasia. And I think there's been a lot of papers recently coming out of Toronto and Simon Kelly looking at the standardization of treatment protocols in children when they're treated early on. Again, if your hip ultrasound isn't, if your Pavlik harness treatment isn't going to plan, and again, this was a baby at 17 days old that was picked up, and these hips did not improve with Pavlik harness treatment. They had 2 weeks of treatment. They looked exactly the same. So it was decided to go for a closed reduction. I hear Bhushan is from Southampton, and this is the discussion we have with Southampton a lot of the time because they don't believe in the power of the closed reduction. So you have a baby now that is 6 weeks old and the hips are dislocated and your Pavlik harness is not working. What are you going to do? Well, if you're in Southampton, you probably wait till you're 12 months of age and have an open reduction, maybe with a pellet acetabuloplasty. Or why don't you use the biological potential of the baby? And again, we work in a children's hospital with pediatric anesthesia, and they are happy to anesthetize 6-week-old. Again, it was the retention principles, and then they went on to the maturation phase, and we followed them up. And again, I think you can all agree that at 4 years of age, bilaterally dislocated hips, these hips look normal. Again, if we'd have had to have done an open reduction on these hips, either medial open reductions at 6 months or even full anterior with an acetabuloplasty at 12 months, the hips never look normal. So in summary, the principles of treatment are reduce, retain, allow maturation until you get an age equivalent mature hip. And again, now that you understand the spectrum of the disease, you can treat each and individual parts of that spectrum. And I would argue, Sandeep said earlier, the incidence of dysplasia is 1 to 2 per thousand. With the spectrum of hip instability, actually it's 3 times that. But you're just not picking it up, and we're probably picking them up late. You can pick it up, and you can have a bespoke, standardized treatment algorithm that's based on really good principles. Again, however you want to do it, as long as you understand the principles, you know, we all have our own opinions on what's the best option for treatment of hips in some cases. Thank you.
Great. Thanks, Claire, for that very lucid talk on how to manage the 3 Rs. And with that, I think I will just hand over the session for discussion to Alaric as to final summary words, as well as then to Viraj as to the next steps that can be taken.
Great. Thank you, Sandeep. And right off, I will begin by thanking Sandeep and Sandeep for taking the step forward in doing this wonderful webinar today. We have had some really wonderful talks. I've enjoyed every single one of them. And this is something that we always struggle with, because on one side, we know what is the ideal thing to be done. On the other side, we live in the real world, and we have to look at things which are practical for our own country. And I'll just share very quickly with you the approach that we have used through the Pediatric Orthopaedic Society of India in developing some guidelines based on literature, trying to see how we can mold that to the healthcare system that we have in India with all of its challenges, and therefore then to see going forward how we can take our next steps. I hope my slides are visible, so I'll go right ahead. And as Claire and the other speakers have shown already, we know that DDH is this large spectrum that ranges from a very mild dysplasia, which is virtually undetectable by clinical methods, to a completely dislocated hip, which is often irreducible. And we also know, as Claire rightly pointed out, that though we talk of an incidence which is 1 in 1,000, we know that the clinical hip instability, especially we check them soon after birth, after the age of 6 weeks, because of the laxity in the ligaments, you can have instability into 1 to 3%. And if you actually do hip ultrasounds in these children early enough, you can find dysplastic changes at about 5 to 15% of neonates. So it's a really high incidence, but the good news is that more than 80% of these unstable or dysplastic hips should resolve within the first 6 to 8 weeks of the child's life. And there have been screening guidelines developed by several organizations across the world, and many countries have developed their own form of guidelines using either selective screening or universal ultrasound screening. And we have debated for many, many decades on the pros and cons of each of these approaches. We must remember that whenever you try and modify or use guidelines, you must always look at your own healthcare system, understand what the challenges are, and even if you have to choose a little imperfect system, but which is more practical for that healthcare system, then maybe that's the right way to go. I don't need to belabor this point. We all know that we are now the largest and the most populous country in the world with a very high birth rate. And looking at that incidence of even 1 in 1,000, which is a very conservative estimate, we are looking at almost 25,000 new cases of DDH every year. And this is just looking at the graph 3s and 4s. We all know the challenges of the healthcare system in India, where we have very little of the money allotted to healthcare. The public healthcare sector is overworked, and a large part of the healthcare is actually provided, even in the rural areas, by the private sector, by small standalone hospitals, and which is quite disorganized, as you can imagine. The other problem that we face in India, which is very unique to our country, which I think no other country suffers from, and I use the word suffer very strongly, is because we have this unique act, which is called the Preconception Prenatal Diagnostic Techniques Act, which is the PCPNDT Act, which was made into law many decades ago so as to try and correct the skewed gender disparity that occurs in India. We know there's a very high incidence of female feticide, especially in rural areas, and that has really skewed the ratio. Hence, the government took a very strong step of bringing ultrasound under its purview, monitoring each and every ultrasound machine, and serving very severe penalties if there are any discrepancies that they find on surprise inspections. The result of that is a powerful investigative tool like ultrasound has been denied to many of us healthcare workers and the patients, not only for the detection of musculoskeletal problems, but for so many other conditions where ultrasound is extremely powerful as an investigative tool. So we have to work within that system, and we understand because of this very stringent act, very few musculoskeletal radiologists are keen to therefore specialize in musculoskeletal ultrasound, and especially more so for neonatal hip ultrasound. So there's this though we have ultrasound machines all over the country, every single public healthcare system has an ultrasound machine, but we have people who are not trained to use them. And if they use them, they're not trained how to interpret those ultrasounds in a neonatal age group. So therefore, we decided that it's time we take the lead in developing some guidelines for India using the evidence that we had from literature. At the same time, getting together these large organizations which serve the children of our country, mainly the Indian Academy of Pediatrics, the National Neonatology Forum. We involved the ultrasound and the radiology group as well. The Obstetric and Gynecology Association, which is a very large organization in India, and the Indian Orthopaedic Association, which is our parent body. And we were very fortunate to have some funding and technical expertise shared by the University of British Columbia, the BC Children's Hospital, and funding from the International Hip Dysplasia Registry and I'm a Hippie Foundation. And I won't get into the details of how we went about it. This was a year-long process where we followed three important steps, each of them lasting for about 4 months or so. The first step was to look at the evidence from the literature and to sensitize our colleagues from the other organizations about the importance of diagnosis of DDH early on in life. Because when we spoke with many pediatricians, they all said, oh, we don't see DDH at all. And the reason they don't see DDH is because they aren't looking for it. And we, who as orthopedic surgeons, are seeing patients coming to us after the walking age when we can no longer use the Pavlik harness or hip spica, but instead have to rely on very extensive reconstructive procedures to correct a simple condition like DDH. So based on that awareness creation, looking at the evidence of literature, and then using the Delphi approach to develop consensus among the group of these stakeholders, we then developed this care pathway for India. And it's available on the POSI website as a free download. If you point your smartphone to this QR code, it'll take you directly to the POSI website. And you can then access the website for the guidelines. We have the details of the entire process, how we went about developing the guidelines and the actual guidelines themselves. And we've kept this as an open source because we want people to actually start using the guidelines, because guidelines which have been developed and just kept on the website are not much use unless they are practically utilized in each healthcare system. And then, of course, we publish this in Indian Pediatrics, which is the official journal of the Indian Academy of Pediatrics, so that the pediatricians and neonatologists are aware, because they are the first responders who are the ones who are going to be looking for DDH when children come to them for their regular assessments. So I'll just quickly highlight what is the unique nature or the USPs of the guidelines that we developed for India. We tweaked the guidelines that were existing to make the guidelines relevant to the Indian healthcare context. In short, made in India for India. And to remain as broad-based as possible to understand the diversity of our healthcare settings, where we have patients who are accessing some extremely good healthcare in the private hospitals and the corporate hospitals in urban centers, but those who are also exposed to the primary healthcare system in rural areas where things are not so great. We emphasize the importance of surveillance rather than screening, and there's a subtle difference between the two. Surveillance indicates this periodic examination, so it takes off the pressure from the neonatologist and the pediatrician that they only have one episode or one encounter with the child where they have to diagnose DDH. What we have done I think more importantly is one thing that India does well is its immunization schedule. We know that the government has really pushed for universal immunization, and we have millions of children who attend the Well Baby clinics at fixed intervals during their childhood, from birth to 5 years of age, and even older, for their vaccinations. And we said that the best way then is to train the people who are sitting in the Well Baby clinics, be they healthcare workers, pediatricians, or neonatologists, to therefore examine the hips, take a few minutes off from the vaccination, and very quickly do a clinical check of these children. We decided that we must use simple clinical tests to make it easy for people to understand and to elicit. And though we know that it's imperfect, and all around the world, people are moving towards universal hip ultrasound, we know for our country, it's not going to work as long as we have this very stringent PCPNDT Act. It's going to take some time before we can bring about an interest in ultrasound and how to interpret ultrasound. So we therefore decided to use the selective ultrasound screening. And more importantly, the last point is that we have lowered the age for when an X-ray can be done. Traditionally, we used to wait for 6 months of age before we would recommend an X-ray. Therefore, this created a gap in the treatment. They would say that the ultrasound is available to around 3 or 4 months of age, so the ossific nucleus starts appearing. And then because we don't have access or the expertise in interpreting ultrasound, then we lose those children for follow-up till they come back at 6 months of age when we would recommend an X-ray. And we're no longer doing that. We have lowered the age for which an X-ray can be done, because we know that X-rays are easily available in the country and they can be used as a screening tool even at a younger age, thanks to the IHDI classification. So of course, this is all available on the website. I'll try and break this down for you very quickly. What we have done is to integrate it, as I've said, with the immunization schedule, and children who come for immunization to the Well Baby clinics come at birth, at 6, 10, and 14 weeks for their vaccines, and then at 6, 9, 12, 15, and 18 months for the remaining vaccine schedule. And to make it simple, we use just 4 basic clinical tests, 2 of them in children less than 3 months of age, 2 of them in children older than 3 months of age, because we know that after 3 months, the Ortholan and the Barlow tests are not reliable indicators for a hip dislocation. So if you have a positive clinical examination, we say you straight away refer that patient to the orthopedic surgeon or the pediatric orthopedic surgeon for further evaluation and treatment. So this is for the pediatrician, neonatologist, or the healthcare worker sitting in that Well Baby clinic before they immunize the child, to do the simple clinical tests of the Ortolani, the Barlow, the Galeazzi, and the limited hip abduction test. If these children don't have a positive clinical sign, any of these 4, and then we talk of risk factor screening. And Sandeep has brought up nicely of the fact that really risk factor screening does have its problems. It's imperfect, but still that's one thing that works for us. So for the risk factor screening, again, to simplify it, we have spoken only of 4 important risk factors. There are a lot of risk factors that you can look at, but you can very easily get confused if you bring up too many risk factors. So we brought in the 4 most important risk factors: a breech presentation, a positive family history in a first or second degree relative, the importance of improper swaddling, because it's rampant in a country like ours, where many, many children are advised by nurses and by the people who conduct deliveries to immobilize or swaddle children in a very unsafe position with the hips and the knees in extension, almost in a mummy-like position. And this is very much ingrained within the Indian culture. So this is a very important risk factor for us, because we know that improper swaddling can lead to hip subluxation and dislocation. And the last one was the hip instability. So if you have any of these risk factors which are present, you then look at the age of the child. And we said, because they're coming at 6, 10, 14 weeks, and then directly at 6 months of age, we said in a child who's less than 6 months, less than 14 weeks, if you have ultrasound available, not just available, but you have someone who can interpret that ultrasound, then you do an ultrasound at 6 weeks. But if you don't have the ultrasound available, you can schedule the patient for an AP pelvis hip X-ray, a single X-ray, not a lateral view, not a frog leg, a simple AP pelvis X-ray at 14 weeks of age. So we have dropped down the age at which an X-ray can be used for screening to 14 weeks. And if this is abnormal, we refer the child to orthopedics. Again, in a child who's between 14 weeks to 6 months, if it's available and you have the expertise to interpret the ultrasound, then you can do it. But otherwise, don't hesitate at that point right away don't call the child back at 6 months, but between 14 weeks to 6 months, at any time you can get an AP pelvis X-ray done. If it's abnormal by the IHDI system, refer the patient on to orthopedics. And of course, any child more than 6 months, don't do the ultrasound, straight away go to the pelvic X-ray. I think this for us is a very important slide, because I think it brings down the fact that we don't need to always depend on the ultrasound. We can use the X-ray as a screening tool, because that is universally available in every single center in India. And the last subgroup, of course, is the unstable hips, or the positive Barlow test. And we know that any child who has a positive Barlow sign beyond 6 weeks of age is abnormal, refer that patient on to ortho immediately. But if the child is less than 6 weeks, again, we have brought down to, do you have the ultrasound available and the expertise to interpret it? If yes, do it at 6 weeks. If no, do an AP pelvis X-ray at 14 weeks of age. And if any of these are abnormal, again, refer to orthopedics. So I think this is, in short, the way that we have, by consensus and by using the evidence from literature, decided that maybe this is the system that will work best for India. We know that we will keep looking at these guidelines every few years or so. And if we find that things need to change, we are happy to do that. In the meantime, we're going ahead with this guidance that we have developed. We are in the process of developing knowledge translation tools in the form of flyers, pictures, and videos, because we know visual images is something that's far better than a whole lines of text. So we're hoping that once we develop these flyers and we have some funding for it, we'll be able to stick it up in each and every well baby clinic, either in the private or in the public healthcare sector. We launched these guidelines at our first mid-year meeting of POSI, which we held in 2022. Not only the DDH, but we also developed guidelines for CP hip surveillance. We had a really intense workshop where we discussed these guidelines at length for over a period of 1.5 days, and then actually formally launched it. So in short, I would acknowledge all the people who worked on this. From POSI, we had many of our leaders and parts of the people from the executive committee. Many of you are on this call who helped out with this entire process. There are many more people that we have also not acknowledged here, and the funding support that we had from our international collaborators, especially Kishore Mulpuri and his team. So in short, I would say that this is the system that we have developed. I would like each and every person from India who's attending this webinar today, that we have heard what is ideal, we have heard what we want to do and what we should be doing. But in the interim, till we don't reach that optimum screening guidelines of using universal hip ultrasound, using the graph technique, try and utilize and incorporate these guidelines into your practice. Change will come not only from top down, by approaching the government and approaching big organizations, which we've already started to do, and to start having discussions with them, but also bottom up. If each and every one of you sitting in your clinic, all of you who are pediatric orthopedists and orthopedic surgeons, if you post these guidelines in your clinic next to you, in your well baby clinic, if you create awareness programs for your neonatologists, the pediatricians, and the healthcare workers who work in the well baby clinic at the time of immunization, I'm sure drop by drop, we will be able to cover the ocean of DDH, which we are seeing. And I hope that over time, we see less and less children who come to us for the first time as orthopedic surgeons after the walking age, where they need these very extensive and elaborate reconstructive procedures. Thank you very much for your attention. And I'm happy to open this up for discussion. If there's any points that our foreign faculty would like to speak about, or if there are any other questions from the people who are attending this, we'd be happy to take them. Thank you.
Thank you, Alaric. It was really eye-opener for many of us. I think, I mean, what Alaric has appealed in order to just move forward with the our goal of treating these babies as fast as possible. So I think there is a need of conducting these courses actually hands-on. So I think Sandeep has already worked with Dr. Sandeep Hemmadi, and they are planning to have the next actual hands-on course in the month of August. Am I right, Sandeep?
Yes, yes. So
maybe
what
Sandeep
we
can
are
give more
hoping,
detail about that. Yeah.
Yeah, what we are hoping is that, like Alaric said, the pediatricians, the gynecologist, and clinical screening plus X-ray at an early age is there. But centers, the urban centers like Mumbai, Pune, Bangalore, Chennai, we need to train enough quality sonologists so that where sonology is available, a proper graph technique can be taught to these people. And we were hoping ICDOE with Sandeep and Clare and Claudia can help us with training people. And the first hands-on training course, Sandeep has promised that he's going to come in August. We are doing it on August 17th in Pune, where they will be bringing phantoms and we'll be arranging for the cradle as well as the arm to hold the probe, which we had done. We had done the first graph course about 20 years ago. It was Joy Patankar's idea, and we have done subsequently 2 courses, but then it sort of fell into a hibernation, and we are now reviving it with our national program. So we'll start training programs once a year probably, so that people cannot say that we don't have access to training for doing good ultrasound. Yeah, Sandeep.
Sorry, yeah, okay. I just want to make a comment. So, Alaric, I absolutely agree. I think your pragmatic guidelines are a very reasonable, starting point, and you still have the ambition to provide the best, diagnostic methods that can be available. I think your guidelines are very similar to the one that Mexico has used. Also realizing the diversity of the healthcare in their country, and they would aim to try and provide ultrasound to all their babies, but they understand that at this moment in time, they have to allow the use of plain X-rays in areas where the ultrasound expertise is not available. So again, a pragmatic view there, lots of public health messaging. They'd like to promote ultrasound as a diagnostic method, but understand that overnight and today they can't suddenly do that. And therefore, they've also used guidelines which have got a mix of plain films and ultrasound. So both good starting points. And now we need to work on providing the training, because like I said earlier, you can have all the money in the world. You can't suddenly tomorrow morning turn on a universal screening program. It takes a lot of time to train a large number of people and then put the resources in place to even consider. You have to run a successful selective training program of a good quality before you can even, aim for a universal screening program.
Great. Thank you, Sandeep. I think our thought process was actually the same. We had to begin somewhere. And we said, rather than going for the optimum, which may not be practical, let's do something which is practical first, and then there's always chance to evolve. So I think that was the whole ethos behind developing these guidelines, that let's make a start, because for so many years we've just been saying we don't have guidelines, we don't have guidelines, we don't have guidelines, and we don't have ultrasound. So what do we do? So then it's rather than just doing nothing, I think let's just use something which is a little bit imperfect. We can use clinical screening, we can use X-rays, and the centers which have the capabilities for doing the graph method, doing the ultrasound, definitely should get that expertise. And that's what we're trying to achieve in the next meeting that we'll have in India. And we'll have many more, as Sandeep has requested through ICODE, if we could do that as well, for the people who want to learn and who have the expertise and who have the availability of ultrasound. Yes, definitely go ahead. We have a great method with the graph technique. We have had lovely talks today from Claudia, Claire, and yourself as well. And we're definitely excited that for centers which have this availability, we should be using that. It's like the Rolls-Royce. If you can afford the Rolls-Royce, why not do it? The other thing that I would add, which is an exciting advance, again, very quickly, is the use of AI. And there have been some talk nowadays because the main problem we've realized with ultrasound in this country is people do not know how to get the standard graph plane. And because of that, the problems go from there. Very often patients come to us with a report, and when we ask them, show us the film, they don't have the film. When you look at the film, we look and we see that the scans are not by any means through the standard plane. And therefore, that report is entirely wrong. So just having those alpha and beta angles when the standard plane has not been achieved, which Claudia and Claire have been belaboring all about in the last couple of hours, then all of that goes to waste. So we're finding now that if we have an AI tool where we can do a sweep of the hip, like a video image, and artificial intelligence finds the standard plane from that video sweep. And then from that, the AI tells you directly, this is the alpha angle, this is the beta angle, this is the femoral head coverage. Or if it found that the sweep was suboptimal, it tells you right away, your sweep was not enough. Please go ahead and repeat the sweep again so that we don't have to send the patient home and come back a second time. This is a pilot study that we are doing in India. Bhushan is leading that study. We've had a pilot so far where we've recruited almost, I think, 900 or more hips. And once we have a sufficient number, we'll probably publish that. And I think that will be a great tool if we can show that AI has some role to play in helping us getting the standard plane. I think that will be a game changer for our program in India, because then we can use that AI, even if it has some issues with it. And we know that we have to train AI again and again and again. It's as much as we train it, that we can then make it simplified in India and say, okay, you don't even have to struggle to get the standard plane. AI will do it for you. And I think that's what we can leverage technology in a country like ours. Thank you very much.
So that was lovely, Alaric. We spoke about it briefly, and we can get our people who are now developing ortho AI tools to help us with probably getting the AI and standardizing the reports so that we can have larger numbers of ultrasound screening for babies rather than relying on you. Ashish in Pune is also committed to I was thinking that we should start, like we said, we have a program, but we should start one city at a time, at least say western part of the country. If Mumbai, Pune decide that we'll make sure that we train enough people as well as start implementing it in most of the city limits at least. I know we can't cover everybody, but we'll have a larger data pool to then excite more people across the country to do it. So on that optimistic note, I think we are exactly at 7 o'clock and we've done well to finish everything on time. And we look forward to Clare, Claudia and Sandeep visit us in Pune and conduct the graph course in August. So on that note, good night, everybody. And thank you, everybody, for your time. It was a wonderful webinar.
Thank you. Thank you, everyone.
Yep.
Thank you. Bye-bye.